45 years from now, I'd like to see NTTCHP
About health in the robotics age.
A full undergraduate course, known globally and internationally, full running basic program.
Nagkaroon na rin kami ng sariling building.
These things may not be here, but one thing
45 years from now, I'd like to see an
45 years from now, I'd like to see NTTCHP
Talking about health in the robotics age.
A full undergraduate course.
known globally and internationally.
Full running PhD program by then.
Magkaroon na rin kami ng sariling building.
These things may not be here yet, but one thing is for sure. Dreams are big in the National Teacher Training Center for the Health Professions. As the second youngest college in the University of the Philippines, Manila, NTTCHP is geared towards expansion and growth, creating huge waves of innovation in the field of health science education in the coming years.
NTTCHP is one of 9 degree granting units of the University of the Philippines, Manila. As a graduate college, we equip health professionals to be effective facilitators of learning, educational planners, evaluators, researchers, managers, and leaders through our various programs. We analyze evidence, we generate knowledge, and from there advocate best practice in all educational settings for the advancement of health professions education.
As of the end of the first semester of 2019 to 2020, the college has produced 95 BCH PED, 101 DH PED, and 189 MH PED graduates who have been appointed to key and strategic positions to contribute to transformative education of health professionals. NTTCHP not only creates impact in Manila, but also in different parts of the world through their international partners, namely Thai Binh Medical University, Hanoi, Vietnam, the University of Health Sciences, Lao People's Democratic Republic, and the University of Health Sciences, Kingdom of Cambodia. From among the mentioned alumni, 16 are DH PED and 12 are MH PED alumni from the Kingdom of Cambodia through a collaboration program with the World Health Organization Western Pacific Regional Office and the French Cooperation.
When teaching and learning in the health sciences first came out in 2010, everybody was quite excited because it was the first textbook from the Philippines in health professions education. It won the most outstanding book awarded by the National Academy of Science and Technology in 2011 by Dr. Badner and I. It was a thought-provoking book that made the concepts of teaching and learning simple.
The National Teacher Training Center for the Health Sciences was founded in January 30, 1975. During the University of the Philippines Board of Regents' 857th meeting, the center, headed by its founding director, Dr. Corazon P. Gonzalez, was under the Dean of the UP College of Medicine, Dr. Florentino B. Herrera Jr. In its 899th meeting, held on March 13, 1978, the UP Board of Regents changed the name of NTTC to the National Teacher Training Center for the Health Professions, or NTTCHP. UP Manila was then declared by the UP Board of Regents as an autonomous unit in the Health Science Campus in 1979.
NTTCHP was founded during the Decada 70 or the first 10 years of martial law. Despite of all the challenges of the 70s, we're able to develop more or less a robust training program for faculty development that eventually resulted to strengthening of the way we teach health professions education.
NTTC-HP was originally a part of the master plan of the World Health Organization or WHO's network of teacher training centers. In 1971, Dr. Corazon P. Gonzalez, then a full-time faculty member of the UP College of Medicine Department of Physiology, was sent to train to the Regional Teacher Training Center in Sydney, Australia. After her training, the WHO was convinced that there's a future of an NTTC based in the University of the Philippines, Manila. WHO noted the strong and positive response of UP Manila to health professions education. May 28, 1981, the UP Board of Regents approved the offering of the MHPA degree program. With this degree program, the NTTC ceased to become a mere service unit and became a degree-granting college of UP Manila.
So in the school year of 2001-2002, the master's degree program in health professions education was developed into a ladderized curriculum. Ladderizing the program allows the students to exit at any point, ending up with a certificate, a diploma, or a master's degree.
Responding to the challenges of the 21st century and in synchrony with the policy standards, the mandate of the University of the Philippines, and the guidelines for graduate education program of the Commission on Higher Education, the college now offers the Master in Health Professions Education or MHPED professional track, consisting of 30 units of coursework, and the Master of Arts in Health Professions Education or MAPED, which is the academic track composed of 24 units of coursework plus 6-unit theses, totaling 30 units. The two master's degree programs include new core and elective courses and reconfigured courses from the ladderized program and capstone project or portfolio. Furthermore, the new DRH-PED professional track program is open to all master's degree holders interested to pursue a career track in advanced HPED fields. It is composed of 26 units of coursework and 12 units of dissertation. Finishers of this program are expected to 1. Pursue careers as health professions education scientists who conduct independent research and contribute new knowledge, methodologies, and technologies. 2. Educational leaders and managers who can address the challenges of the 21st century higher education institutions. And 3. Agents of transformative learning.
NTTC-HP's curriculum is offered in both residential and off-campus platforms. It was first offered in off-campus mode in Cebu Institute of Medicine from 2004 to 2008, then in the Kingdom of Cambodia from 2012 to 2015. At that time, NTTC-HP was recognized as one of 2 of WHO's Regional Education Development Center in the Health Professions Education in the Western Pacific region. In 2015, NTTC-HP's curriculum was again offered as off-campus mode in Cebu Institute of Medicine and Southwestern University, FINMA.
The National Teacher Training Center for the Health Professions is proud to have 7 heads of units from its foundation. They are the ones who greatly shaped the college over the years and give it its deserving prestige and platform. From 1 full-time and 2 part-time faculty members, NTTC-HP now has an impressive lineup of professors. The research extension and professional staff of NTTC-HP is also composed of 2 researchers and 2 library personnel. And there are 6 administrative staff. After 45 years, and true to the original World Health Organization mandate, NTTC-HP, through its alumni from different institutions, paved the way for the creation of 8 medical education units, namely UP College of Medicine, the University of Santo Tomas Faculty of Medicine and Surgery, the University of the East Ramon Magsaysay Memorial Medical Center, and Manila Central University in the National Capital Region, De La Salle Medical and Health Sciences Institutes in Luzon, Cebu Institute of Medicine, and the West Visayas State University College of Medicine in the Visayas and Davao Medical School Foundation, College of Medicine in Mindanao. In 2012, the Educational Development Centers for the Health Professions were also founded in the University of Health Sciences, Kingdom of Cambodia, and Lao People's Democratic Republic. The 21st century brings new and emerging roles for the present health professions educators. NTTCHP responds by offering its revised outcome-based and blended learning postgraduate curriculum in 2020. The college will continue to offer relevant programs, conduct research and extension services that meet the challenges and gaps of the time in the Philippines and in the Western Pacific region. With all these trusts and accomplishments, NTTCHP hopes to be recognized as a national center for excellence for teacher education and the World Health Organization's collaborating center in health professions education.
Good afternoon, everyone. Welcome to the second to the last seminar series for the 2021. Right now, we have more than 100 in our Zoom room meeting. And also, we would like to remind everyone to please mute your mic and turn off your videos throughout the presentation. But you can always type your questions or comments in our chat box. Clinical teachers have a very important yet a difficult task of developing students' clinical skills. This task became even more challenging during the pandemic since students need to assess, diagnose, and manage patients and clients in an online platform. Today's seminar hopes to answer the teacher's question on how to develop telehealth consultation skills among students. Let me first start by introducing our moderator for today. Dr. Maria Lourdes Dorothy S. Salvacion is a graduate of the University of the Philippines College of Dentistry. She is an alumna of the Master in Health Professions Education program here at NTTCHP. And currently, she is the chair of the Office of the Curriculum and Instruction. Ladies and gentlemen, our moderator for today, Dr. Maria Lourdes Dorothy S. Salvacion.
Okay. Good afternoon, everyone. Welcome to NTTCHP. So today's topic is developing teleconsultation skills in health sciences students. So telehealth, like online learning, was something that the COVID pandemic brought in its wake. And more than a year and a half later, we have realized, again, just like online learning, that it is here to stay. So I don't know what your experience have been, on what side of the telehealth monitor you have sat, no? Either as a patient or as a practitioner, but definitely we have all experienced it by now, and we all have questions. How should it be done? What are the best practices? And more importantly for us, health professionals, educators, how do we now teach our students the necessary skills for an effective telehealth practice? So we at NTTCHP, ever sensitive to your needs, have prepared this afternoon's event. This particular session will follow a symposium format. Each speaker is given 30 minutes to speak on their assigned topic, and then a forum will follow to allow participants to ask their questions and share their views. So without further ado, I would like to introduce our distinguished panel of speakers. So the first speaker is Professor Lourdes Marie S. Tejero. She is currently the Director of the Technology Transfer and Business Development Office at UP Manila. Dr. Tejero also served as Dean at the UP College of Nursing and Director of the National Graduate Office of the Health Sciences. Professor Tejero graduated from the University of California, Berkeley and UC San Francisco with a Master of Translational Medicine. She completed her bachelor and PhD in nursing from UP. She did her postdoctorate at the University of Technology, Sydney. So she will be speaking on the legal, ethical, and professional issues in teleconsultation. The next three speakers will talk about developing teleconsultation skills of students in their respective fields. To speak for the nursing profession, we have Professor Arnold B. Peralta. Arnold Bolares Peralta is an assistant professor at the UP College of Nursing. He is the head of the teaching program of the college and in charge of the following nursing programs: Bachelor's degree in nursing, Master of Arts in nursing, and the Doctor of Philosophy in nursing. He received both the bachelor and master's degree from the University of the Philippines, the BS Nursing from the College of Nursing, and the Masters of Health Professions Education from the NTTCHP. And he received his Master of Arts in Nursing from the University of San Carlos. So he's currently finishing his PhD in Education Curriculum Studies at UP Diliman. So the next speaker will speak on teaching telerehabilitation skills in physical therapy. This is Professor Raisa R. Ruiz. She's an instructor from the Department of Physical Therapy of the UP College of Allied Medical Professions, where she received her BS Physical Therapy degree. She has served as a clinical training coordinator of the physical therapy interns since the last academic year. She also serves as a clinical supervisor under the Camp Clinic for Therapy Services for almost 5 years now. With the current shift into the service learning delivery of the clinic for therapy services, she currently provides telerehabilitation services for adult patients of varying conditions. And then our final speaker will speak on teaching teleconsultation skills in medicine. We have Professor Iris Tel Isiptan. Dr. Isiptan is an academician and clinician, internist, endocrinologist with a special interest in health informatics, particularly in the use of mobile technology and social media. Dr. Iris graduated BS Medicine from the University of the Philippines College of Medicine. She then took her Master of Science in Health Informatics and is currently finishing her PhD in Health Sciences by Research. Currently, she is a professor at the UP College of Medicine, the chief of the Medical Informatics Unit since 2012, and the director of the Interactive Learning Center since 2016. In 2014, she was the Philippines College of Physicians Presidential Awardee for Social Media Advocacy. And 2015, she was the first recipient of the UP System Gawad Pangulo Awardee for Progressive Teaching and Learning. And she is one of the 2021 Metrobank Foundation Outstanding Filipinos. So there you have our impressive lineup of speakers. So without further ado, let us listen to their presentations.
Good day, everyone. So I'm Professor Lourdes Marie Tejero, the Present Director of the Technology Transfer and Business Development Office. And thank you to the NTTC for inviting me here, and I commend the group for coming up with this very important topic. So we're going to talk about now the ethics in telehealth, which is now being done in greater scale than before because of the COVID pandemic.
The title for my talk is Ethical, Legal, and Professional Issues in Teleconsultation. So as you can see here, these are the objectives for this presentation. So we're going to tackle the ethical and professional issues in teleconsultation and also how probably to address these. And we will be looking at relevant laws and memoranda and how these would apply to actual teleconsultation experiences. Yes, there is a DOH and National Privacy Commission Joint Circular issued in 2020. And this is on the use of telemedicine in COVID-19 response. So this is very timely because this is the topic of the presentation. We'll look more into this. While telemedicine is encouraged, the gold standard for clinical care remains to be face-to-face consultation. So that's the number one in the Declaration of Principles for the Joint Circular. The patient-physician relationship shall be based on full knowledge of the patient's medical history and a physical examination given the circumstances of a lack of physical contact. So as much as possible, the physician should get the full knowledge of the medical history and a PE. In case the patient is referred to a health facility, the physician who initially sees the patient shall be responsible for the coordination of care. And lastly, emergency and serious condition where face-to-face assessment and physical contact are most essential should not be managed via telemedicine. So this should be referred immediately. So these are the necessary information regarding the features of the telemedicine visit, fully discussed with the patient for the informed consent. So firstly, how telemedicine works. These are the components that should be in the informed consent. How referral is to be done. The privacy concerns. The risk of technology failure, including confidentiality breach. So, for example, the instability of the internet. So it should be included in the informed consent. And lastly, the policy on care coordination. As we said earlier, it's the physician who's talking with the patient should be the one coordinating the care of the patient. So here is a sample of an informed consent form. This is published or included in the works of Dr. Isip Tan and colleagues, Telemedicine Guidance for Physicians in the Philippines. So we can see here some of the components. The purpose is in here in the introduction, the first 3 paragraphs. And then you see here the nature of telemedicine consultation. You can actually look into the details here on the left part of the slide. And then the benefits. So what's going to be the benefits for the patients? And then potential risks. There are important things that the patient should know, and risks would be one of them. On the second page of it, you have here the data privacy and confidentiality. So it says here, I agree to share my personal data, etc. So the rights of the patients. I have the right to 1, 2, 3, 4. No? 1, to ask non-medical staff to leave the telemedicine consultation room, for example. So this is a sample of the informed consent. And then the limitations, the clarity of the images. It's very important for the patient to know. And then referral in case of need for urgent emergency care. So for electronic documentation, all healthcare providers are authorized in the interim to issue documents like electronic clinical abstract, consultation summary, and or referral form, if applicable to the patient. These documents must be suitable for optimal character recognition or OCR by being typewritten. The documents shall be issued via email or acceptable modes under the Electronic Commerce Act of 2020. The RA 8792 gives legal recognition to such, like the electronic data messages, the electronic documents, and electronic signature. Yes, they are now legal documents. So for record keeping, all physicians whose services are sought through telemedicine shall keep records of all electronic clinical abstracts, consultation summaries, prescriptions, and or referral forms issued in coordination with the DOH telemedicine partner. So these are important records that physicians should keep. All healthcare providers shall at all times ensure that patient confidentiality, privacy, and data integrity are not compromised. So it is the responsibility of all healthcare providers. So doctors, nurses, and all other health professionals. So these are the ethical guidelines in telemedicine issued by the World Medical Association. And I got this also from the work of Dr. Isip Tan and colleagues. So there should be mutual trust and respect between patient and physician. And this should be maintained all throughout the teleconsultation. There should be confidentiality, privacy, and integrity ensured. And we have discussed that even before in the previous slides. The informed consent should be obtained, and the specifics of it had been itemized. So autonomy and privacy of the physician should be valued in as much as we also value the autonomy and privacy of the patient. The physician should perform the basic responsibilities and ensure quality care all throughout the teleconsultation. So these are some relevant ethical questions that Reinitz and et al. In 2016 had reported in their telehealth consultation skills among students that they taught. So they were asking, what could you do if your indigenous patient refuses to be filmed? Well, this is the refusal of your patient, so honor it. Another question is, what could you do if the teleconnection fails? And which happens very often, right? Well, attempts should be made to connect again, and whatever had transpired in that teleconsultation prior is also a legal communication between the patient and the physician. And why is recording of the interview not encouraged? Because like any medical records, there could be confidential information that would be there. And can a patient with psychosis give informed consent to a teleconsultation? A patient with psychosis has some impediments in terms of the exercise of freedom and will, because the psychosis itself can actually diminish that capacity of the patient to think well, think through things, and also to give the consent. So there should be somebody, a family member perhaps, who can give the full consent. Now let's go to some relevant laws. And RA Republic Act 10173 is the Data Privacy Act of 2012. This is going to be relevant for our topic on teleconsultation. On Section 11 of that law, the Data Privacy Act of 2012, we have the processing of personal information. So what would be the meaning of that? So the processing of personal information shall be allowed subject to compliance with the requirements of this act and other laws allowing disclosure of information to the public and adherence to the principles of transparency, legitimate purpose, and proportionality. What do you mean by transparency? The data subject must be aware of the nature, purpose, and extent of the processing of his or her personal data, including the risks and safeguards involved. the identity of personal information controller, his or her rights as a data subject, and how these can be exercised. Any information and communication relating to the processing of personal data should be easy to access and understand, using clear and plain language. Now, what does legitimate purpose mean? The processing of information shall be compatible with a declared and specified purpose, which must not be and not excessive in relation to a declared and specified purpose. Personal data shall be processed only if the purpose of the processing could not reasonably be fulfilled by other means. So now let's look at processing, which refers to any operation performed upon the personal data that was gathered. So these operations would include, but not limited to, the collection, recording, organization, storage, updating or modification, retrieval, consultation, use, consolidation, blocking, erasure, or destruction of data. So any of these would be the processing of the personal data. And this is important to underline as we talk about what really is being done on my personal information. So, personal information must be collected for specified and legitimate purposes determined and declared. It should be adequate and not excessive in relation to the purposes. We have actually discussed that in the Declaration of the Principles, and retained only for as long as needed. That's why even in research, we include there in the informed consent that we will retain the information only for a year, a duration of the research, which is 2 years probably. So that is also the right for the patient to know how long it's going to be retained. So what's the criteria for lawful processing of personal information? So these are the criteria. Please don't mind the numbers here. But the topmost is that the data subject has given his or her consent. So always the patient should give consent. And then fulfillment of a contract with the data subject. And then for compliance with legal obligation to which the personal information controller is subject. And to protect vitally important interests of the data subject, including life and death. So that means when the patient or the one whose information is being processed, there is a danger in the life and health of the person, and it needs to be processed, the personal information, then that's part of the lawful, one of the criteria to process. And then to respond to national emergency, yes, the COVID-19 is an emergency, and we'll see more aspects of it later on. And for purposes of the legitimate interests pursued by the personal information controller. So, or maybe the institution like the DOH or the NIH, etc. So the following are the rights of the data subject. So this is important not only for patients but also for us, because many times we put our information on the internet and many other things that we process our information in. So one is to be informed about the processing of the personal information. So for what's going to be used, how it's going to be used, and be furnished with the following information. Description of what information will be entered into the system, the purposes, because we have underlined earlier on, we need to know for what purpose, and the scope and method on the processing of that information. The recipients to whom it will be given, is it going to be the general public, is it going to be the hospital only, hospital personnel? The methods utilized for the automated access, what EMR, what platform is going to be used, the identity and contact details of the personal information controller, we need to know that. The period, so the length of time, the existence of their rights, so what's my right? You can actually access that, you can correct the information, you can check it out, so all these are the rights of the data. Now, part of the rights of the data subject would be to access upon demand the following: the contents of my information, your information that were processed. The sources, where did you get this? That's why you have the right to ask. Where did you get my credentials? The names and addresses of recipients. Very detailed names and addresses. I would like to know who got my information. Manner by which such data were processed. How did this person get my information? By email, or is it by the system? By what system? The reasons for the disclosure. Why did this particular person or group of persons get my information? The information, the automated processes, the date when his or her personal information was accessed last and modified. Very detailed. The designation or name of or identity and address of the person who is controlling, or who is managing our information. So we have these additional rights of the data subject. I'm emphasizing this because we are all part of it and we should know our rights. So we have the right to dispute the inaccuracy or error in the personal information and have the personal information controller corrected. And so if you see that the information put in our records is inaccurate, we can actually elevate it to the ones in charge. We can also suspend, withdraw, or order the blocking, removal, destroy my information. That's why in research, if they don't want anymore to proceed and they say, please remove my data from your bank or system, and then be indemnified for any damages sustained due to such inaccurate, incompetent, outdated, false, unlawfully obtained, or unauthorized use of personal information. So if suddenly we see our face there or a name there, so we can remove, not only remove it, be indemnified for any damages. So this is something interesting. What should you do in the event of a data breach? So we have actually a law that requires a data breach notification to the NPC within 72 hours. So this is also part of the Data Privacy Act. So the NPC is the National Privacy Commission. So 72 hours. So notification is required when the breach involves sensitive information. Suddenly your diagnosis is out there in the open or it's in social media. So information that may be used to enable identity fraud. So there's so much fraud already ongoing. Everyone is wired during this pandemic and fraud abounds. Information has been acquired by an unauthorized person. So this, let's say, criminal got our information and is about to do something unlawful against us. The acquisition is likely to give rise to serious harm to the affected data subject. So we report it immediately to the NPC. So we've seen the laws and relevant memos. Let's look at actual situations happening now. And I'm getting part from the Rappler's report. This was in June 2020. As the number of coronavirus cases in the Philippines steadily increased from mid-March to late May, the NPC had been investigating 22 complaints of privacy breaches involving more than 150 COVID-19 patients, as well as suspected and probable cases. So these are unauthorized disclosure of COVID-19 patients' identities. And especially in 2020, June, that was the height of it all. And we don't have yet the established things like what we have now in 2021. So even then, there were already 22 complaints. And among those being investigated by the NPC was the leaked manifest of the medical evacuation plane that crashed at the NAIA in late March, revealing the names of the passengers and crew. The screenshot of the manifest made the rounds on social media. And that's private information being leaked into the social media. So there have been a lot of talk about this. People saying, well, this is, it has a basis because we are in pandemic. It's a national emergency. It's for the health and for the welfare of the entire country or entire world. That's why you need to identify who have the COVID-19 disease now. You can also argue that there may be no need to reveal individuals' personal information. So far, having the numbers and their location may be already enough for people to be protected. If needed, that we reveal all these information, we need to get their permission and encourage people to be the ones to reveal their own journey. And that's why, even in 2020, people had been coming out in the open and saying, I am a COVID-19 patient. No? When stigma is put on these people, people were already coming out to say their diagnosis. So we've heard a lot about South Korea being one of those countries that had effectively done their surveillance and how they have actually balanced data privacy versus public health safety. And they use a lot of electronic tracing. South Korea protects personal data under their Personal Information Protection Act, and they take personal data very seriously, but in case of a public health emergency, they subscribe to the health officials' guidelines under the IDCPA. So in addition to punitive measures against hacking, preventive measures against the collection of data leading to negative human influence on AI systems in the machine learning process are also needed, as evidenced by the shutdown of South Korea's AI chatbot, iRuda, due to the use of hate speech in the system's learning process. Progress toward the anonymization of personal data is seen as a positive step to defend personal freedom in the data-driven world under COVID-19. One recent measure in South Korea that the other democracies might consider is the use of anonymized personal codes to replace QR check-ins at public venues for entry. And I think it's something that we can actually adopt here in the Philippines. Instead of something that's the public QR code, we can have our anonymized personal codes. And this is now my penultimate slide, the disclosure of health information. I'm taking it from the article, journal article of Lofredo in 2020. The common rule is confidentiality and privacy of information is not absolute. The basic ground for breaching is the primacy of public health and safety over individual right to privacy. But care must be taken to ensure that patients are not discriminated and stigmatized as a result of the breach of confidentiality and privacy of medical data. The rule of thumb given by the Philippine NPC is gather only what is necessary and disclose only to proper authorities. Breaching does not mean disclosed data is universally accessible. Governments must ensure that confidentiality remains protected even when such right is temporarily withheld as demanded by the principles of respect of persons, human dignity, autonomy, and justice. And with that, ladies and gentlemen, this is again Professor Tejero, and I hope that you were able to gain insights as to the ethical, legal, and professional issues, as well as how to address these issues in teleconsultation. Thank you for listening.
Good afternoon, everyone. First of all, I would like to thank the NTTC for this opportunity to share with you what the College of Nursing is working in relation to improving and addressing the delivery of nursing education amidst the pandemic. Recently, telehealth, telemedicine, telenursing have become remarkably important due to increased deployment and development of digital technologies. During the COVID-19, mandatory social distancing, lockdowns, stay-at-home protocols, and the lack of effective treatments has made telehealth the safest interactive system between patients, both infected and uninfected, and also for us healthcare providers. Let me start my presentation with the following outline. First, I would like to briefly introduce the UPC and BSN curriculum and some key areas in the program. Next would be the design principle that we use in the shift to remote learning, the skills needed in doing the teleconsultation, and lastly, some recommendations we can share with you if you need or if you plan to have teleconsultation be integrated in your teaching learning activities. Learning in the clinical environment has been extensively researched and established the clinical setting as a powerful environment for learning. The process of learning of occupations through experiences in the circumstances of practice is well and highly proven and has stood the test of time. In teaching nursing, it is important to provide students with opportunities to number one, engage effectively with and be guided by more experienced nurses in the wards, and thereby learn through and from them. Next is to identify and engage with effort any activities that might be seen as being particularly helpful to their learning. For example, pedagogically rich activities. Sometimes we ask our students to observe, to assist professional nurses in the wards. Next is find ways of engaging with peers and use these interactions to inform, consolidate, and use these interactions to extend what they are learning in their practice experiences. And lastly, engage effectively and actively and purposefully during these experiences to maximize the learning potential of the opportunities afforded them in this practice setting. Knowing this, the nursing curriculum is one of the degree programs which is badly affected when face-to-face classes are shot. The UPCN Bachelor of Science in Nursing program is outcomes-based, value-based, community-oriented program. In the program, we are allocating around 2,200 hours for clinicals and field work, which include hospital rotation, community and health center experiences. In the identification and performance of outcomes, the College of Nursing utilizes this framework. As you can see in the slide, as the student goes through the program, the students will have the opportunity to provide care in different levels of clientele, namely individuals, families, special population groups, and communities. These students perform their roles and responsibilities as researchers, leader manager, client care provider, and or practitioner. Integrated in the provision of care is the increasing complexities of interventions covering the concepts of health and illness and the levels of prevention. I would like to share with you the UPCN framework in curricular design. As you can see, we started with the scenario setting, which include the demographic profile. So one example for this is that in our new curriculum, in our new program, we already included the gerontology nursing. Well, given the fact that in the Philippines, we have now an aging population. Next is the health picture. No? And one good example for this is the inclusion of the disaster nursing in our program. And lastly, social, political, economic, cultural context to be the basis for selecting the teaching learning activities and learning experiences we want to provide to our students, which can be in the form of clinical rotation, practicum, or field work. After hearing our program, I would like to proceed with how telehealth is seen or recognized in the program. No? Telehealth is using technology to provide the healthcare remotely to address the continuous increase in the demand of care. I would like to emphasize or highlight in the demand of care, because I think this one is very important and very evident right now as we redesign the courses and realizing the challenges accompanying it. Some examples of telehealth activities include replacing the face-to-face visits with the e-visits via the use of video conferencing, monitoring movements in and around the home via activity monitors, and monitoring vital signs such as BP, blood pressure, heart rate, blood glucose levels, or via devices for self-measurement. Just to give you an idea that telehealth is recognized with these global standards. No? On a global level, the importance of telehealth competencies for nurses is highlighted in different standards. Well, number one is the tuning framework in Europe, the Australian qualifications framework, American Nurses Association, and even the World Health Organization. A new approach to the frame of competencies or outcomes in healthcare domains is the use of entrustable activities. This is defined as the tasks or responsibilities to be entrusted to the unsupervised execution by a trainee, for us nursing students, once he or she has attained sufficient specific competence. The concept of entrustable professional activities were designed to link the competencies to clinical practice for curriculum development and the teaching assessment. So in the study of Van Howell and Jen in 2015, they identified 14 nurse telehealth entrustable professional activities relevant for nursing practice. We have supporting patients in the use of technology, training patients in the use of technology as a way to strengthen their social network, providing health promotion remotely, triaging incoming calls and alarms, analyzing and interpreting incoming data derived from automatic devices for self-measurement, monitoring body functions and lifestyle, providing psychosocial support, encouraging patients to undertake health promotion activities, instructing patients and family caregivers in self-care, assessing patient capacity to use telehealth, evaluating and adjusting the patient care plan, coordination of care with the use of telehealth technology, independent of double check of high-risk medication, guidance, and free consultation. After hearing those entrustable professional activities in nursing, you will notice that these activities can be categorized to the nursing process. When you try to think of the steps or in terms of the activities, you will see that it can be under the assessment, it can be under the nursing diagnosis, planning, intervention, and evaluation. Specific competencies for the provision of telehealth. Again, this is from the article from Van Howell and Jen in 2015. I only selected a few and I just selected those I think relevant and something that we can use in terms of integrating this into our teaching learning activities. For the knowledge category, specific competencies include clinical knowledge, knowledge of policies, procedures, and protocols of the organization, or for example, the institution where you want your students to be deployed. For example, the Philippine General Hospital, uh, or the LGU, no, concerning the deployment of the organization of telehealth technologies, knowledge of how to collect health-related data for patient monitoring, and knowledge about what to do if the technology does not work. For the attitude, specific competencies include this patient can convey empathy through video conferencing by facial expression and verbal communication, is able to promote privacy and confidentiality in video conferencing. Motivational attitude is able to enhance the confidence of patient in the deployed technology. For general skills, analytical skills, when we expect our students to think creatively to solve the problems, coaching skills, protects the privacy of self and the patient in the use of the telehealth technologies. For technological skills, specific competencies include is able to train the patient to use the equipment, basic ICT skills such as the use of internet and a personal computer, is able to check equipment for functionality, technological skills in the field of new technology. For clinical skills, specific competencies include able to combine clinical experience effectively with telehealth technology in decision making, observation skills, interprets nonverbal, verbal expressions in the right way when video conferencing, able to use the health-related data effectively in patient care, communication skills, and implementation skills. I'm sure while you are listening to the specific competencies, you realize that there are competencies that we are already performing. These competencies, or there are competencies mentioned or in the list which we just need, to rethink and strengthen. And also there are competencies that are new to us, and we need to consider to include in our teaching learning activities if we really want telenursing or telehealth nursing to be part of our teaching learning activities. Now I will move to the part, I will share with you what we have done in one of our courses requiring these competencies or requiring these teaching learning activities. This is from the article published by our faculty assistant professor and the head of our research and creative writing program, Assistant Professor Erwin William Leyva, together with our faculty Assistant Professor Maria Angela Mabale, Assistant Professor Josephine Carriazo, and Miss Alexandra Bernal. This is in relation to our experience as we shifted to online learning, particularly the experience of the intensive community health nursing course. The intensive community health nursing course has been traditionally 8 weeks, where the students stay in rural community. This is being implemented in Cavite, where various colleges of UP Manila are also working together through the UP Manila Community Health Development Program. The expected competencies of the course revolves around using public health tools in planning, implementing, and evaluating community-based health programs using a primary healthcare approach or primary healthcare framework. Other competencies expected are on conducting participatory research, capacity building through training of community health workers and partners, And most especially, the students are expected to provide care, provide direct care through the health center. This is one major competencies or expectations where the telehealth can be integrated. The competencies were reviewed by the faculty members in charge of the course in terms of what can be demonstrated online and which ones would be limited given the outcomes of the course. As they review, they see that there are competencies that really require actual clients. In terms of family health nursing, the students were asked to identify 5 families where they were expected to provide care online. The faculty were aware that there may be limitations in the demonstration of some specific competencies such as physical assessment, assessment of environmental hazards, and others which may require ocular survey. Limitations may also exist in terms of the information they can generate from the clients, as this will be mainly those from the interviews. The plans of activities were presented to the director and personnel of the Community Health and Development Program of UP Manila, and these activities were acceptable to them. But these have to be reviewed again by the local government unit. Most of the activities were implemented as planned. Unfortunately, the municipalities became preoccupied with its COVID response when the surge went on, and therefore stay-at-home protocols were placed, which made our barangay health workers or the community health workers unable to attend the online meetings. The family health nursing went through as planned. In terms of the readiness of our students and our community partners, the team conducted a survey. Based on the survey of the graduating students enrolled in that course, nearly 46%, each are within NCR or in Luzon but outside NCR. The remaining students are in Visayas and in Mindanao. During that time, the course was offered last year. So the COVID-19 travel restrictions will make it is improbable for many students to come in for in-person classes. Half of them also reported difficulties in performing at least one of their daily activities. The data suggests that there are degree of remote supervision and support needed by the students as they cope with COVID-19 related disruptions. The survey also asked about the financial status because we want to check if the family can afford, the needed technology to deliver the online care. For example, the gadgets and internet connection. We also did a survey to the barangay health workers and community organizer. Fortunately, 82% of them are willing to collaborate with our students. So they're very willing to help implement the course for at least 1 hour to at most 1 day per week for the activities of the students. As we did the first course, actually that course is we offered that with the N1 to 1.1. So that's the intensive nursing experience in the hospital. But in that course, we did it virtually. But in the community, we included telehealth in that delivery. So we want to share some issues and challenges and opportunities that we are willing to address and share with you the opportunities that if you want to do it in your courses or in your program. According to Jones 2020, potential influencers include awareness, perception, and engagement, policies, and its context. So during that time, at the initial months of the pandemic, the usual policies governing nursing education from the government regulating agencies remained in effect. So meaning they do not have any new or revisions in that memorandum. So we are still following certain rules, for example, the required number of clinical hours for graduation, and this is also needed in terms of allowing the students to sit in the board exam, no? Having the complete or having the required number of hours. And at the college level, the UP College of Nursing, we are also guided with our curriculum in terms of the implementation. So um, again, we did not revise as much in the content, but it's in the delivery of the course. Another item here is the institutional barriers or enablers, which include organizational goal, culture, context, and setting. So this will focus on the access and availability of technology. As the premier state university of the country, the University of the Philippines aims to produce highly motivated and competent nurses. Its core values include nationalism, integrity, caring, excellence, and love for learning, which is integrated in our courses and also in the whole program. The existence of online learning platforms such as the UP Manila Virtual Learning Environment or our VLE or the Canvas were instrumental during the shift to open or to remote learning. However, we also recognize the barriers in terms of technology existed both from the students and also from the side of our community partners. The third item is motivation for learning. According again to Jones in 2020, learners, facilitators, barriers, or enablers include demands, motivation, digital literacy, and access and resources. When we did our survey, one of the results were that our students are very much eager to graduate by the end of the semester last year. So I think this is a very positive thing because we try to analyze this from the results and we come up that our students need to graduate on time or as early as possible because they need to work already. They need to do the next steps, for example, review for the board exam and eventually pass it and work as professional nurses. However, during that time, many reported disruptions in their way of life and that they were busy in coping with this. So the motivation for learning is also not that maximized or full because there are so many external factors affecting their motivation. Some students reported feelings of anxiety and stress from the course requirements as well as uncertainty for the family safety during the pandemic. And lastly, the delivery mechanism, which include the curriculum content. Although we decided that the content should be remain the same, but in the delivery or approach can be changed. As the expected competencies remain the same, the main challenge of the faculty was to identify creative alternative learning activities that best enable the students to demonstrate the outcomes. After hearing those challenges and also the opportunities, I hope that we are all again motivated and we all after 18 months of doing this, I hope we are now ready to face this new normal. So let me just end this presentation with a quote from William Osler. The trained nurse has become one of the great blessings of humanity. taking place beside the physician and the priest. And with that, again, I would like to thank you everyone for listening and enjoy the rest of the day.
Teaching clinical reasoning and psychomotor skills are crucial in making sure that our interns achieve the skills that is required of an entry-level physical therapy clinician before they graduate. Typically, interns would be rotating in hospitals or clinics. They would undergo the PT process to manage clients or patients based from the APTA guide to physical therapist practice. So they would undergo examination and evaluation of the client. They would create PT diagnosis and their plan of care, including PT prognosis. They would implement PT interventions, and later on, they would also assess the outcomes, no, to check the progress of their clients. So how did we shift all of this into telerehabilitation? Although this is not an entirely new concept, last academic year was the first time that the PT department of UP Camp has officially used this mode of service learning delivery. So what changed, and how do we ensure that the students still learn despite the internship being in a remote setup? So hi, I'm Riser Ruiz. I'm a physical therapist and a faculty from the UP College of Allied Medical Professions, and I'm one of the academic and clinical training coordinator for the PT interns since last academic year until this year. And today, on behalf of the PT department of UP Camp, I will be sharing our experiences in teaching telerehab in physical therapy. So let's go through the PT process that I have mentioned earlier and how we have been teaching these processes in the telerehab setup. So starting off with the examination and evaluation, where we still do history taking and interview. Nothing much has changed from how we previously do this and how we teach this. No, we still do simulations where we ask our students to role play an interview. It's just that in this setup, no, we have to practice this via doing video calls or audio calls. No, so they would need to practice conducting the simulation in platforms like Zoom. We also provide them with case-based activities where they can plan their pre-assessment image, and basing on that, no, they would start creating their interview questions as well. So what are the particular changes that has occurred, no, in this setup? We still do synchronous sessions where we do the interview via video call or audio call. However, we also observe that there is a lag time in between asking questions and waiting for the reply of the patient and the caregivers. So it could get time consuming to do the synchronous interviews. So lately, we have also been exploring the use of asynchronous history taking and interview questioning. So we do this in the form of online survey forms or via text messaging or emailing them. An example of which is seen here in the screen, where we gave access to the caregivers to answer an online questionnaire. So next, we also still do our PT assessments and interventions. What changed is that in face-to-face, no, we would have wanted to practice the skill during lab sessions, where the students can role play as both a PT and a patient. But in a remote setup, we need to consider that conducting these psychomotor skills would require a lot of space, materials, and equipment, and they would even need to have a simulated patient to practice the skill. So we have to shift how the students can practice these necessary skills at home. Our best option is to actually provide them with instructional materials that they can try out, no, at home. We ask them to invite their family members or their household members to act as simulated patients so they can practice. They would then record themselves, and this is in the form of creating video portfolios so we can assess how they did the skills at home. Or we can also ask them to attend synchronous classes where they can do the demo and return demonstration of the particular skills. So we still do case-based activities like giving them hypothetical cases where they can plan out the assessment, and then later on, hypothetical cases where they can start creating their treatment plan. So in this setup, we usually do this in a synchronous class or asynchronous means. For synchronous sessions, they can do this in video call like this one, or in asynchronous means, they would answer case-based activities via the chosen platforms of the faculty. So in Telerehab, how do we shift the assessment and treatment in this setup? We mainly rely on synchronous sessions, mainly video calls, occasionally audio calls, so we can instruct our patients and observe them in real time. However, there would be cases that internet connection might be a problem. So we can also send out asynchronous instructions via message or email. And then later on, we would ask the patients to record themselves doing the particular activity. And then they will send it back to us. So here you can see an example of us instructing the patient. So we have recorded them. So the caregiver in blue is assisting us in providing guarding and observing the patients for safety. And then we just observe how the patient does the activity. So what are the particular changes that we had to consider when our interns conduct this part of the PT process? So we mainly observe that our usual choices of PT assessments are not viable in this setup. So there is heavy reliance in observational skills. We have a difficulty in using standardized outcome measures. So we mostly utilize non-standardized outcomes due to the limitations in space and the available equipment that is standardized as well. Although we can recreate some of these standardized measures in the homes of the patients, the findings that we get is not 100% ensured to be comparable to the normative values that are available. So the next best thing that we can do is to consider this quantifying results as baseline scores instead. And then we ask our interns to take note of the particular setups that they used so they can recreate them later on for the re-evaluation phase or even during for the treatment sessions. We also have to take into consideration small nuances like camera angles. Since we rely heavily on observation, in this setup, we need to maximize the view that we see our clients in order to get substantial information from them. So that would mean that the interns have to factor in which plane of motion or views they would need to do in order to best see and observe the client's performance. And given that we are heavily reliant on observation, not everything can be assessed by just a visual inspection. So there is a risk as well of having an unanswered hypothesis throughout the sessions. The interns also need to utilize the available materials and environment in the patient's home, which might take a little bit of trial and error, but we have observed that this has worked well for us as long as we emphasize the importance of utilizing this for later purposes as well. What's important to teach our interns is for them to not box their therapy sessions in just this four corners of the screen, and not just in front of the screen. So they really need to explore the environment and not be afraid to move the camera around and even ask the patients to explore available spaces and materials around their home. So for pedia patients in particular, the interns need to make sure that the environment that they would ask the caregivers to set up should be engaging but not distracting. no? So there are a lot of rearranging home furnitures and a lot of materials that are needed to be rearranged in their home setups, no? So a good thing about this is that since we are already doing the therapy sessions at home, we can make our activities as salient as possible, no, and as applicable in their home environment as possible, so that they can recreate them whenever they need to. Okay. We also observe that we need the active participation of the caregiver, um, mainly as our main assistant, no, during the session. So we really need their help in setting up environment and providing manual assistance and guarding the patient in terms of safety, and mainly acting as the warm body that does the tactile cues for us, no, the manual assist that we cannot do since we are in this setup. So here, as you can see in this particular example, we are asking the caregiver to kindly set up the environment for us. In PEDIA, we also seek the caregiver's assistance in conducting behavioral management techniques as well. No? A challenge for the interns is that they would really need to delineate the instructions that they provide to the caregivers, no, that they would need the assistance in this particular portions, and the instructions that they would provide to the caregivers. So this could take a little bit more time than usual since we are instructing a lot of people in the session and not just the patient. So next, we also ask our interns to consider the safety, in particular of the patient. No? So even before we see the clients, in the clinic, we have an eligibility criteria for patients, in order to conduct telehealth sessions with them. This would usually entail asking them materials that they have, if they have good internet connection, if they have devices that they can use for video call and synchronous sessions, if they would have an available person that can assist them, during the session. So the presence of the caregiver is particularly important. In terms of safety, we ask our interns to make sure that they mitigate any risks, especially since we are not there in the same environment with the client and the caregiver. So this would occasionally entail them to ask the caregivers to arrange the home environment to make sure that the patient is safe, and to ensure that there would be safety devices, that are in place where the patient can hold on to, or rest stations that would allow them to have breaks in between the session. Would also ask the interns, to consider what monitoring devices they would need, during the session. So in general, we would usually use vital signs as one of our main monitoring system. So the availability of the devices that the patient and the caregiver would need, in order to monitor the vital signs should be present in the session. Then for us PTs, we use a lot of queuing, in various forms such as visual, verbal, and tactile cues. However, in this particular setup, we rely heavily on visual and verbal cues, and there is less emphasis on the tactile cues since, again, we are not with the patient in real time. So for our interns, we teach them to utilize the functions of the platforms, that would supplement their visual and auditory cues to the patient. So that could include using a share screen function, for example, in Zoom, or preparing recorded videos at hand, in order to share it to the caregivers, so they would know what to do. In this particular example here, we have a screenshot of the patient and the caregiver watching our share screen, where we are showing them how we will do the assessment and how the caregiver will assist us in providing the resistance, to the patient. So next, the rest of the PT process, no, like the PT diagnosis, planning the PT prognosis, and the rest of the plan of care. No, we usually do clinical reasoning activities. So nothing much has changed in these areas as well. We still do case-based activities where we emphasize to the students that they need to look for the best evidence, no, in order to create the best treatment, no, for the patient, no. So how do we do this in telerehab, no? So mainly we do our processing synchronously primarily, no. So we do, of course, set up video call sessions and discussions with our interns where we can talk about the findings that they got, and then we process it with them. And then we also emphasize the collaboration with the client and the caregiver, no, later on. We also do this asynchronously where our interns send out their documentations. No, this could be in the form of Google Docs, no, where we can readily provide feedback and comments in the same document. So what is really being emphasized in this current setup is that we need to maximize the collaborative practice with our patient and caregiver. No, since we are already in their home setup, no, we can readily check the goals that we have set for them in their home environment. And in order for us to do this, no, we really need the input of the patient and the caregiver, since they are the ones who know their home setup really well. So finally, how do we assess and give feedback to the interns? So for us, of course, the interns would get feedback, no, from the faculty that has been assigned to them, no, the clinical supervisor. So like in face-to-face sessions, no, we do set up feedback sessions with them before, during, and after patient care sessions. No, so particularly for the before and after patient care sessions, no, in this setup we would do video call discussions, no, with the students. No, we can also again provide feedback asynchronously via their documentations. So what's particularly interesting about the current setup that we have is that we can actually provide discrete feedbacks, no, during the session themselves. So this is done through direct messaging, no. So we can use a pre-planned platform where we can message each other, no, without needing to alert the caregiver or the patient, no, during the session themselves. So for Zoom, this is where the direct message function comes in. So if there is a need for the supervisor to provide immediate feedback, but does not necessarily need to cut in between the video call session, now, they can discreetly send instructions to the intern via these direct messages. Other ways that the interns can get feedback is through their own self-reflection and from their peers as well. No? So all sessions are suggested to be recorded. No? This is particularly for CTS, no, for the clinic for therapy services. We are asked to record our sessions, no, for the safety of the patient and the clinicians as well, and for proper documentation of our sessions. No. We do ensure data privacy wherein only the people involved are able to access these recordings. We also have a different setup this year wherein the students work together in groups, no? Still within the suggested ratio of one supervisor to a maximum of 4 interns. No, so when they do this, no, they can change up their roles within the session. So some of these students would be facilitating the activity while the others could be observing their peers. No, so in this case, we also facilitate peer learning. No, so the observers can take down notes about the performance of their peers, and then they can provide that feedback later on. No, when we discuss our during our feedback sessions with them. The interns can also do own self-reflection, no, self-feedback. This is done through reflective practice. So one particularly new thing in this current setup is that we ask our interns, no, to fill out the cryptic form. This is an acronym for clinical reasoning, your PT internal check form. So here, as you can see from the screen, these are some of the items that we asked them. This is from Professor Esmerita Rutor, and it has been implemented last year when we started doing these activities. This provides the intern some form of self-reflection guide questions, no, where they can see their progress, no, during their patient care activities. In particular to their own self-reflection, no, they can also review the recording of the session, no, in order to see their own particular performances. So lastly for us, no, in order for the clinical supervisors to provide graded, no, numerical grades to the skills that they have shown, no, we have revised our grading rubric, no, that would be tailor fitted to the tele-rehab setup that we have right now. An example here, as you can see, is that we have a particular criteria, no, that would ensure that we cover how the interns exercise PT and client positioning in a telehealth setup. No? So as you can see here, we have included items like how they use the optimal positioning of the cameras, of the caregiver, and how they would do the activities. No? What's a good thing about the current setup as well, since we already have a recording, no, we can look back at their performances readily, no, and that would give us more time to reflect as well on the grades that we provide and the feedback that we provide these interns. So we can even provide na explicit na examples of our of their performances, no, that we provide feedback to. And that's actually it. That's the end of this presentation. So I hope you learned something new from how we do our teaching in this tele-rehab setup. And if you do have any questions, my email and my communication lines are open for any questions, and during this day as well. So thank you for listening, and yep, see you all around.
Okay, so good afternoon. Thank you for this opportunity to discuss the process of integrating telemedicine in the postgraduate curriculum. This integration has been on my mind since last year when we at the Medical Informatics Unit released our guidance documents on telemedicine. In fact, the very first document we finished last April 2020 identified the needed competencies for telemedicine, and this was amid the sudden shift at that time to telemedicine, given that clinics were closed due to the community quarantine. So, but let me warn you, implementing telemedicine education requires a change in culture. And that with rapid advances in technology, effective and successful physicians will need to know the fundamentals of health informatics and its application to medicine. And way before the pandemic, I was already campaigning for the inclusion of health informatics in the undergraduate medical curriculum. But our discussion for today is on the postgrad. So let me make it clear that telemedicine will never replace the gold standard of face-to-face visits. But this pandemic has made it abundantly clear that moving forward, those in the health professions will need telemedicine skills. So I've divided my presentation into three parts. First, to take a look at the telemedicine competencies needed in the postgraduate curriculum. Then to examine the teaching strategies and assessments that have been tried elsewhere and that I'm looking forward to trying. So let's start with the competencies. So whichever telemedicine curriculum you look at, you'll find the same three components. So the first component is the telemedicine technology. Whichever platform is used, be it audio or video, the residents will need an orientation. We must not assume that because they are millennials and therefore digital natives, that they will automatically know what to do with the technology. Most importantly, we need to emphasize procedures to protect our patients' privacy and confidentiality. This is especially problematic in our local setting where messaging apps not designed for telemedicine are still being used. The second core component is communication and examination skills. We will need to teach our residents the web-side manner. And from our MIU telemedicine guidance document, our acronym is WISERP. WISERP, or maybe just say wiser physician. So W is for welcoming the patient. I is to introduce the technology because we have to acknowledge that this is not the usual way we are doing things. S is to set the agenda for the visit. E is to express empathy. R is to reflectively listen. And P to provide closure. So most telemed platforms will allow screen sharing, and I saw that in Ma'am Rice's presentation as well. And this opens up the possibility of graphic-assisted communication. So physical examination will be limited even in a video visit, but residents will need to learn patient-assisted physical examination skills, which can enhance the yield of virtual visits, which can hopefully obviate the need for subsequent face-to-face encounters. The third component is medical, legal, and licensing aspects. First, the scope of telemedicine use, which though some medical organizations locally have already set standards of care, our legislation in support of telemedicine is still lacking. So given that our residents are trainees and are under our supervision, we need to teach them how to recognize when telemedicine service is safe, clinically indicated, and within the purview of their educational licenses. So the last being an issue of direct faculty supervision when our residents are conducting virtual visits. So I'd like to suggest a fourth component, and that is the electronic consultation. This allows primary care clinicians, for example, to submit electronic clinical referrals and inquiries to specialists and engage in virtual dialogue regarding patient management. In this dialogue, the specialist can communicate with the requesting clinician and either give clinical management recommendations or determine that an in-person specialist visit is required. And this is especially important in our context of universal healthcare and service delivery networks. Our trainees will need to learn how to optimize effective communication and enhance care coordination through this electronic consultation. Commonly, our residents refer to us, right? They might send us a Viber message updating us about our patients. As a student, naabot ako pa yung pager. But here, what we're really looking at is because this is telemedicine, it will differ in that we need to coordinate care not only within, but beyond the hospital to the community. So the e-consult card that is shown here and in the next slide provides a framework that training programs can use to approach electronic consultations. So E is evaluate. Does the patient require an in-person visit with a specialist, or can this be addressed by an electronic consultation? C, clinical question, a focused and direct question for the consultant. Objective data, specific information relevant to the clinical question. And narrative, the subjective information. So in this e-consult framework, so it's SULT. I particularly find interesting here in this second part is L, the length of time, and T, teamwork. It should be part of etiquette and know when to expect our reply. This is an urgent referral and I need a reply right away. Or for T, teamwork, identification of other relevant members in the patient's care team who may benefit from knowing the results of the electronic consultation. So do you have a team messaging function in your electronic medical record, or is everything coordinated via Viber? So next up, I will show you some telepsychiatry competencies. I choose to share this in particular because I love the way that they organized it into domains. So they said you need competencies as a medical expert, communicator, collaborator, manager, and advocate. So for technical skills, we need to train our residents on optimal visualization, background, lighting, and framing. So optimal visualization means the patient can see you as if at clinic. And if the angle is wrong, like right now I'm talking to you live, if the angle is wrong, the patient might see up my nose or will only see my forehead. So we also need to teach our residents that. Proper background, lighting, and framing are essential, as we do not want to distract patients with a cluttered background, a ghostly or pale appearance, or an off-center view. So definitely, the resident should know how to troubleshoot the telemed platform should audio or video get cut off. Now, compliance, not only with the standards of medical care, but also with the Data Privacy Act, will have to be part of our curriculum. So assessment, this is for telepsychiatry. That's why it includes, for example, a mental status exam. But certainly the other competencies here apply broadly to other specialties. Especially now in our information-rich environment, our residents do need to integrate multiple streams and sources of information. So in remote patient monitoring, for example, I'm an endocrinologist. So sometimes I will ask the patient to email their blood pressure or blood sugar readings because I need to adjust the medication in between visits. So dati nasa papel yan, they bring yung notebook to the clinic. Now it's still the same. They take a photo of the notebook, but then they send it to me via email. Communicator. So while this is specific again for telepsychiatry, the other things here apply broadly to other specialties. So as the patient connects via video from their homes, it is now possible with the patient's permission to assess safety, cleanliness, and activities of daily living beyond the traditional patient encounter. And again, earlier I saw in Ma'am Raisa's presentation that they were taking a look at the surroundings or the environment, which is something that needs to be evaluated in particular for PT. So that is a competency we need to teach even outside of PT. And then because, the relative abroad or the child who's usually at work can now join the telemedicine visit, the residents will also need competency for managing family dynamics. Now, pertinent to universal healthcare, residents enhance their communication skills to engage in collaborative models. For example, bringing specialist care to places without specialists and being able to coordinate care even at a distance. So telemedicine provides opportunity for our residents to collaborate with interprofessional providers across the distance. So locally, even before the pandemic, we know that the thrust of telemedicine has been to reach geographically isolated and disadvantaged areas. And so in doing so, it allows our residents to better understand the community and its available resources. If patients are followed up, even when they return to their community, our residents are then able to appreciate continuity of care in its truest sense. A telemedicine rotation may also improve the writing of consultation notes that are relevant in the community context and resources. So think about the last endorsement note you received. Did it contain some details or did it just say endorsing the patient for follow-up with you as he is transferring to Manila? And then no other details. Manager. Yes, our trainees will also need administrative abilities to understand how the technology network is organized, accessed, and administered in the proximal and distal ends. So last year, I remember a telemedicine platform provider asked me, since I was doing telemedicine lectures, if I could explain what a BAA or a business associate agreement was. Because according to him, some local physicians refused to sign BAA agreements with the telemedicine provider platform. But this is really actually in compliance with US data privacy regulation. Advocate. So a telemedicine rotation that bridges care to geographically isolated and disadvantaged areas can help our trainees appreciate the social determinants of health and how the lack of access to care may influence patient presentation, as well as become sensitive to local cultures, beliefs, and healing practices. So it may allow our trainees to reflect on their own social position and their role in the healthcare system. Tumatawag. Okay. So, a telemedicine rotation also strengthens the role of trainees as advocates for the use of technology to address health human resource problems and systemic inequities in access to care. It will help them to see things through a health systems lens. So that's all about the competencies. Now let's go into the teaching strategies that have been tried for telemedicine training in the postgraduate curriculum specifically. So this is a model tele-neurology curriculum with 11 hours of training. I don't know if we have neurologists in the audience. Okay. So it's divided into knowledge, attitudes, and skills. And again, you can see the core components I showed you earlier: technical competency, communication, examination skills, and medical legal issues. But I was thinking when I saw this, then we need to figure out how many hours for each of these. And we need to do that for our residency and fellowship training programs. So how was that operationalized? So this paper describes an experiential teleneurology curriculum for third year and fourth year residents. So first, they have a 60-minute interactive lecture. And I was amazed that they were able to pack in so much because they said evolution of telemedicine, common telemedicine delivery modalities, technological aspects, licensure, reimbursement, teleneurologic exam, website manners, challenges, and future applications. All that in a 60-minute interactive lecture. Then that was followed by two-week blocks of outpatient neurology, which is their usual rotation. But they rotate through the usual clinics, but they pick the clinics. So movement disorders, general neurology, neuromuscular, and epilepsy. But they also had to do e-consultations, which was the one I talked to you about, electronic consultations, where you have to do asynchronous messaging with other members of the team. After the first 2-week block, they undergo an assessment, and I'll talk more about assessment in the last part of my talk, but here they had a quiz and they had self-assessment, and then they have the next 2-week block of outpatient neurology. So it's really integrated into their usual rotation. Next, I'm going to show you an example from pediatrics. So pediatric residency. So what they did was 3 Zoom sessions were integrated in the residents' month-long ambulatory or OPD rotation. So the first session was didactics on the basic principles of telemedicine. So like how to join, set up, document, and bill. So I was thinking, wow, pati billing, okay? And then perform key components of the physical exam. And then sessions 2 and 3 were case-based sessions in an attending facilitated morning report format. So sort of like our morning endorsements. And then they also gave an opportunity for the residents to share interesting and challenging cases so that they could together discuss how to do things better, take better care of their patients using telemedicine. The next few slides I will show you come from this article, and it shows us some sample case presentations and their learning objectives. So for example, they had a case presentation of a 2-week-old male infant with vomiting. And the learning objectives were to assess hydration at the telemedicine encounter and to differentiate physiologic versus pathologic concerns. So I'm showing these cases so that maybe for your own specialty, if it's not pediatrics, we will have to think about similar cases for our own training programs. And then a 3-week-old male with a red bumpy rash and a new red spot near the lip. So this is an interesting case because the learning objective is about being able to instruct the family to take good photos and to send it to the telemedicine application, and then for the resident to learn how to view those images inside the application. So from experience, this can be challenging to do, and it's really something our residents need to learn, like how to angle the camera. You have to teach the patients that how to take good photos, natural light, etc. Not too near. Should there be flash or no flash? And then the perspective. So if they take it from top down, then you'll have a different view of the lesion. Abdominal pain. So now this is really a telemedicine challenge where the trainee will have to be assisted. In this case, because it's a pediatric case, the resident has to be assisted by the parents for the physical exam maneuvers, but also learning to assess when it is necessary to refer for an in-person evaluation. Now, how about complex cases? So such cases will be a good opportunity for trainees to identify appropriate visit types for telemedicine and how telemedicine can be used for care coordination, as patients with complex cases are often seen by a healthcare team. So this is really looking forward, because right now, when we talk about telemedicine use in our current training programs, it's because we have restrictions because of quarantine, etc. But really moving forward, we really have to think about having hybrid visits, that some of them will be via telemedicine and the others will be face-to-face. And what would be appropriate, so in a complex case, the patient doesn't have to keep on coming back to the hospital because some visits can be conducted via telemed. Now, the pediatric residents were also directly observed. So it's not all Zoom sessions. So they were actually asked to conduct virtual visits and they were directly observed. They were given formative feedback using a direct observation telemedicine skills checklist, which I will show later. And according to the authors, this was possible for the attending physicians to observe the virtual visit, as their telemedicine platform allowed for multiple providers to log on together. So currently in my private practice, I use doxy.me, and in that particular platform, it allows for multiple people to join from inside of visit. So I guess that's also possible. Now, this paper describes an interesting longitudinal interdisciplinary simulation to train internal medicine residents in complex care. So this is actually a 3-session but 5-week rotation. So in the first session, they meet their standardized patient. Okay, so but first there will be an orientation with didactic on screening for social determinants of health and OSCE instructions to address psychosocial factors. So the stations, there are standardized patients, and there are 3 stations. So the first will emphasize the televisit OSCE, and then the second station on e-consultation and messaging, and the last will be virtual examination tools. And then over 4 weeks in between sessions, because there's going to be a session 1 and then toward the end, a session 2. So there's an inter-visit simulation. So the patient that they met on session 1, there will be now a nursing e-message sent to the participants that your patient is decompensating. So you now need to have a series of e-consultations between the participant and specialty providers. And this is how they will exercise, learning how to address that e-nursing message. And in this particular example written by the authors, the learner has to coordinate with the social worker, with the pain management physician, and the psychiatry provider. And it's all going to be using e-messages done asynchronously. So this was done online. So, and I thought it was a cool way to simulate longitudinal care via telemedicine. And that experience of the simulation actually feeds into session 2. Session 2 is a simulation of an interdisciplinary conference. So because, they had to take care of this patient over 4 weeks, now they have to have a meeting about the patient. So first, there's a 20-minute didactic on interdisciplinary care and teleconferencing. So this is to orient the participants how it's done. And then the group will now get 40 minutes to prepare for the actual teleconference. The actual interdisciplinary conference will last for 45 minutes. And then afterwards, there's a 15-minute debriefing. So this is the longitudinal interdisciplinary simulation, and it looks fun to try. So the last example is still for internal medicine residency, and this time it showcases a more longitudinal curriculum because they have something for every year of the 3-year IM residency. So in the first year, they actually introduce the residents to the telemedicine equipment. They get an overview of the processes, and they tour a telehealth center. So that's about an hour. And then in year 2, they get didactic and in-person education and online modules. I'll show you in the next slide what the modules look like. And in year 3, that's the only time where they are allowed to experience telemedicine. And even so, they are allowed to do so in a low-risk setting through remote monitoring of chronic disease. So I'll explain that later. So what are the mandatory web-based modules for second year? So these are history and changing models of care, access and population health, technology, infrastructure and applications, legislation and regulation, team-based care, and community partnerships. So all of these 5 modules, they must complete it, but they are given the whole year of year 2 to complete it. So that's a flexible time limit for them to complete, but they are mandatory. And then in year 3, the IM residents rotate 1 half day per week during at least one of their month-long OPD rotations. And what are they asked to do? They are asked to review patient-obtained glucose and blood pressure readings and recommend medication titration and or lifestyle modification. And then we have outpatient general IM faculty overseeing the care. So lastly, let's talk about assessment. So there are many ways, and for teleneurology, the following were recommended: direct supervision of the residents' teleneurology history and examination skills, case simulations to assess website manners, and OSCE of different teleneurology cases. They also said you can have clinical vignettes, and then you can have journal clubs or self-reflection essays on the future role of teleneurology. So I'll show you some of the clinical vignettes that they had suggested. Here, just the usual teleneurology history and examination. So what I like about this, which is why I'm sharing it, because they also categorized it as to encounter type. Is it an initial televisit or a follow-up? And what the setting was. And then a listing of our skills that are demonstrated. So for example, I like here that they included do's and don'ts of documentation. In our medical informatics unit guidance documents, we had a documentation template because we need additional details. Example, the duration of the visit in minutes, who was present in the virtual visit, the reason why it was a virtual visit, where both the physician and the patient are located, and if there were any technical problems during the visit and how these were resolved. We also recommended that the patient be provided a post-visit summary. So this is an interesting vignette from personal experience doing troubleshooting because it can be both frustrating for the patient and the physician. So, and then being able to give instructions on what to do. And then I mentioned this earlier, website manners. So this is definitely needed for our trainees. For example, I have seen patient complaints about abruptly ending the visit or the lack of rapport from a physician. Interestingly, just last week, I saw a tweet where a patient was complaining because his physician was conducting the televisit while inside a moving car. Okay, so then this is another interesting vignette because you have 2 visits. So one is the initial emergency visit and a subsequent outpatient visit. So we generally don't recommend emergency visits, but it happens, right? And you are seeing the patient have a stroke while you're on the televisit. So there's really some things that needed to be done there, like the telestroke history and examination. And abroad, there are telestroke units actually. And then here, it's both outpatient this time, but again, 2 visits because there's initial visit and then a subsequent follow-up visit because this is progressive cognitive decline. And so there should be like a discussion of the plan with the patient and family and advanced care planning. So I'm really showing this so that you can all also think about what vignettes you might want to do for your own trainees. Okay? So lastly, we'll take a look at this direct observation telemedicine skills checklist from the telemedicine curriculum from pediatrics that I showed you earlier. So there's a list, and this is several slides long. But here I was struck by this first skill that says ensure environmental privacy, both for the patient and provider. So in some of the guidelines that I read, they require, for example, that the patient pans the room and also the physician pans the room to show each other that there's only the two of them in the teleconsult, and there are no other people who might overhear or see what is being done. Okay, and then here, the last one is also interesting. Create notes with correct verbiage needed for billing purposes. So we also have to teach our trainees this skill if, for example, PhilHealth will start reimbursing telemedicine. And then for this next items, note the last skill on relevant observations from the video of the environment. So I mentioned this earlier, as the patients are connecting from their homes here because it's pediatrics, they look at home equipment, crib safety, but that's also taking for our geriatric patients, fall prevention, etc. So there are things that we can now do if our patients, of course, give consent. So Lawrence observes that while domains such as professionalism, communication, and other interpersonal skills are often asked of evaluators as part of a general evaluation of trainees, these domains are rarely explicitly adapted to the virtual encounter. And that's why I really like this direct observation telemedicine skills list. And I think this is the last list, okay? So here at the very last, it says, offer a clear explanation of the treatment plan and the next steps of the family. Allow the parent or patient to disconnect first. So this is to avoid what they call the doorknob moment. So remember, at the clinic, I'm seeing a patient. The patient stands up, says goodbye, prepares to leave the consultation room, but at the last minute, hand on the doorknob, turns back to the doctor and asks one last question. In a teleconsultation, there's no such opportunity if the doctor logs off first. So that's the reason why it says allow the parent or the patient to disconnect first. And so I have gone through with you the competencies needed, the model teaching strategies, some sample assessments for integrating telemedicine in the postgraduate curriculum. We all have to work on these for our own training programs. I know I've made a module for telediabetes, but not for residents, for second-year medical students. And therein lies the final challenge. And what is that? An important challenge to adopting telemedicine curriculum is finding faculty educators with sufficient telemedicine experience, and this will entail substantial faculty development and education. But I guess we're off to a good start because we have this session today from the NTTC. Thank you very much.
Okay, thank you very much to all our speakers. Even before the lecture started, there was one comment in the chat box that this is a very impressive lineup of speakers. So, but after everybody has spoken, I think we have an equally impressed lineup of participants. No? So at least we are impressed. I'm sure everybody was impressed. So that was very enlightening, everybody. Thank you very much. And especially, so now at the beginning I was saying that telemedicine is here to stay, and now I realize that that is a bit, that has a note of resignation in it, you know, like something like COVID came and we were stuck with telemedicine as a necessary like alternative. No? In fact, that's what it's called. It's an alternative delivery, service delivery platform. No? But now we are so enlightened that this is not just an alternative. This is actually a new frontier, no, for medicine and for health delivery. No? It is a new frontier which I think we really need to discover and maximize, because it's true. This is actually one way of maximizing the care that we give, no? Because not everything needs to be face-to-face. So, but we have not really tried to identify what are these things that can be done. effectively, efficiently through remote platforms. So that was really very exciting and futuristic, and yeah, so much, parang may homework tayong lahat, ano. For all of our professions to identify, no, and then to create the curriculum, no, for teaching. Okay, so I was actually giving the audience time, no, to write down their questions. So because we are about to open the floor, no, to your questions. I'm sure there are many. Maybe they were so engrossed listening that they didn't have time to write down. So now we will start to open the floor to questions. I will maybe look at the chat box also. Okay. Okay, most of them are expressing their appreciation. But I think there was one at the very start, even before the last speaker, Dr. Iris, our neurologist, Dr. Generaldo Maylem, commented, no, that he was touched by the mention of the nursing profession as with the inclusion of the priest, no? So the nursing, a trained nurse, no, is something. What was that, Arnold? Something that you associated with the physician and the priest. No? Like a trained nurse is something in between the physician and the priest. And so I think Dr. Maylem would like to know, no, what specific roles were you thinking of, or what do you like to introduce, no, into the role of the nurse?
Yes, opo. Dun yun sa last kong slide yata, yung sa may quote about yung nurse, a trained nurse as a blessing, no? Because you have parang the whole spectrum of care, yung nurse yung kasama niya po doon. So ako naman, well, in the program, in the BSF program, we include spirituality as part of our as part of the interventions we are teaching our students. So, well, syempre may mga, well, in terms of spirituality in the more general sense naman din. We also do referrals to chaplain, parang ganun. We also do referrals to any religious, but the point here is that we are teaching our students that the whole spectrum of care and the whole aspect of the human as our client to be integrated in terms of their nursing actions and nursing interventions.
Okay. Yes, thank you very much. So incorporating spirituality into your care. Okay. There is a question from Limuel Anthony. Sorry, hindi ko kompleto yung name na nakikita po. Okay, for Ma'am Iris. For medical interns who we engage for the teleconsultation services of their clinical rotations, how many sessions do you suggest we can have for their training?
That's a very tough question, Lims. But in the literature I reviewed, it really depends on how you structure your assessment. So in the direct observation telemedicine skills checklist, do you let them go once they've demonstrated enough proficiency after one session only, or you make them do some more until they're happy and they feel competent to do this? And I think a very key part would be doing direct supervision, which I realize is very hard. To be doing direct supervision, because it means you'll have to be there in the virtual visit together with the student. So I didn't discuss that today because my emphasis was on postgrad, but in another presentation, the format they used was first, the medical student will have to call the patient. So that's his responsibility, to call the patient to enter, for example, the Zoom room or whatever it is you're using. Then the medical student introduces already what they're going to do. And then the medical student gives a signal to the consultant to enter the room. The medical student introduces the consultant, and then, it could be that the consultant will be running the televisit, and the medical student will be observed. And then at the end of the visit, the medical student summarizes what happened for the patient, and then they let the patient log off, and then they have a session where they talk about what happened and how it didn't go, and they said that maybe later, if they feel that the student is able to do this, the consultant will still be there, but they'll be keeping quiet, and it's the medical student doing everything. So I don't know, I don't really have like the number. It really depends on how confident they will be.
Okay, thank you very much. Okay, there are a lot of questions, so I will ask Claire to help me. Maybe we can do alternate. No, I will read one question, then as I'm looking for the next question, Claire, you can ask the next one. No? Okay, so right now I am looking at one question from Ellen Go. No? I think that a high level of expertise is required for physical examination part in teaching telehealth, since one may need a more complex and imaginative mind to require patients' assistance in conducting the telehealth consultation, I suppose. How do we teach telehealth physical examination when they can't even do basic physical examination? So I remember also when Raisa was talking about especially the caregivers. No? So I was thinking, so now we don't only train our students, we're also training the caregivers at home. So we need to teach them physical examination skills. So I think that is where this question is going. How do we teach telehealth physical examination skills, not just to our students, but even to the caregivers? No? So there's like a basic skills. So would you like to answer that, Raisa?
Yes. So for the PT, so I guess we really have to sort of balance it as well on what physical examinations we can actually teach the caregivers, no, when we want their assistance. So for us, since we had at least a year of experience doing this setup, the department has a little bit more of an idea on what physical examinations are, we would say, easier to teach to a lay person that they can assist us with. No? So most of these assistance that we would need would likely be coming from them merely holding a specific limb for us, or having them palpate an area for us and then telling us how they feel when they were touching specific areas, pero not much on the complicated physical assessments. So that's why I also mentioned there might be an answered hypothesis throughout your assessments, because we can't really teach everything. We don't expect that our caregivers will be able to help us in really using the skills that we are teaching our students that they would take years even to master. No? So we only factor in those that can be easily done, and not much on the thinking process for them. No? So for us, how we sort of bridge this is that during the years that they're not yet an intern. No? So for us, in the new curriculum, they would have opportunities, no, during their second year up until their third year, wherein they can practice specific skills, how they would usually do it in a face-to-face setup. So during the past year, and even until now, we are also incorporating activities on how we can, on how they can think about translating those specific assessments into a telehealth setup as well. So we would ask them to practice the basic skills first on how they would usually do it in face-to-face. And then we would pick some of those assessments or physical examinations that we would like them to try out doing in a telehealth setup. No? So they still also do the simulations, how they would usually do it in face-to-face. It's just that they're doing it in a platform like this, no? And how they would imagine instructing a patient and their caregiver assisting them doing the setup. So that's it for the EDs.
Okay. Iris, did you want to answer also?
It really has to be something that we try to simplify. I was trying to find the slides of Dr. Lisa Traboco, one of my students. She's a rheumatologist, and she actually came up with a poem that's sort of like Simon says, and then she demonstrates, and then the patient follows. And then she says, okay, we've evaluated these following joints. We just take a simple thing that they ask the patient to do, and then she can evaluate actually all of the joints in the body, I think. We really have to come up with those ways to make it enjoyable and sort of simple for our patients. And then we can also teach that to our students if they're really going to do their teleconsultation physical exams.
Yes. So we are really being challenged. No? Our creativity, no? Imagination and creativity is being challenged. No? Claire, do you have a question?
Yes, ma'am. I think this is for Dr. Iris Tan. Do you think a subject on medical informatics should be included in the medical curriculum, and in what period?
Oh, it's already included, but my point was it's only an elective. So for the UP College of Medicine, it's an elective that's needed in second-year medical school. But I know, for example, in Ateneo, I think it's already a required course. And I don't know for the other schools, the difficulty being there are not enough teachers with medical informatics know how to actually be teaching the classes. So hopefully that will be a gateway as well, because I would think telemedicine would be classified under health informatics. And if you think that telemedicine is important, then telemedicine, then medical informatics should be the curriculum as well.
Okay. Yes. Okay, yeah. That was actually, I had a similar question, no? Now that we are so enthused, no? Especially in the area of creating curriculums, no? For empowering our students to do telemedicine. No? So if you happen to have your course, maybe you can create a course. Iris, we are all waiting to enroll. So
I do have that elective, ma'am, for medical informatics, but it's for second-year medical students.
Yes. So there's nothing open. No? So it will have to be through the seminars, no? The monthly SEM. So maybe the next series will be all Dr. Tan. No? Okay. So I have a question here. I have a question regarding informed consent for telemedicine, because we still don't have it, but we have teleconsultation. Should it be institutional or can it be departmental? Can we follow the format of the informed consent presented? Do we need to coordinate with DPO to construct informed consent for telemedicine? So it will have to be Dr. Iris again to answer, because Dr. Lourdes Tejero, no, had to attend to an urgent meeting, no? Concurrent meeting. So although she did tell us that if there are any questions related to her lecture, they can just write it down or email it, write it in the chat box or email it to the NTTC HP official email, and we will collate them and send them to her, and she promised to reply, and we will send it to them, no? But for the moment, maybe Iris can respond.
In the chat box, I actually put there our bit.ly account. So it's bit.ly/UPMIU Telemed 2020. And that actually contains our guidance documents. In the first document, we already had a sample template for consent for telemedicine. It has all the necessary elements in it. That's why it's, I think, 3 pages long. And our suggestion then was to show this template to your data privacy or your data protection officer, or if you're in a hospital or in a clinic, show it to the lawyers to make sure that, baka they might want to add some other things to the informed consent. So it can be an institutional informed consent, but the thing is, you really have to ask the patient to sign at every visit, because that's the other question. They said, like, if I did a telemedicine visit once with the patient, for the second visit, does the patient have to sign again a consent form? And the lawyers told us every time you need to ask them to sign a consent, because that's the safer option for us as healthcare professionals seeing this patient.
There's one question actually for Ms. Raida. How many patients does each intern have?
Yes, good question. Para din po sa answer kanina ni Doc Irie. So, it really depends on the situation. On our end, since I'm also a clinical training coordinator, we would at least like to abide by the current regulations that are being set by PRC and CHED for physical therapists. So currently, we're still using, I think, the same regulations pa rin as before, that interns should have a certain number of hours for their clinical activities. So that has something to do with patient care related activities. So for us, what we have currently set up is that interns should at least have 2 patient care sessions. That's the minimum per week. No? So that would include planning sessions as well, the feedback session. So all of those are counted as their clinical activity hours. So not just the synchronous session with the patients themselves. No? So whenever they need to set up discussion sessions with their peers, with their clinical supervisors, that is also included for that session. So since all of those sessions would usually take more time as compared to how we do it usually in face-to-face, so we have counted that at least 2 patient care sessions should be done. So that doesn't usually mean that you need to have 2 patients always. So it could be 1 patient that you are meeting twice a week. So for you to cover that. So that's at least our minimum. And since we are outcomes based as well, no, like the other white colleges, we would like to ensure that even if they have a minimum of 2 patient care sessions per week, they should still at least meet the overall outcomes of their course, no, prior to their graduation. No? So by the end of the year, they should at least cover all of those PT processes that I have mentioned in my slides, and they should be able to have experiences with different conditions of patients in order to cover those.
Okay, thank you very much. I would just like to inform the group that we are actually way ahead of schedule. Paumpisa pa lang yung question and answer, yung open forum. Kasi 3:45 to 4:15 yung schedule for the open forum. So we can really take our time, and if you have your questions, just put them in the chat box or raise your virtual hand and we can call you. There is a question from Professor Erlin, no, about nursing informatics. No? So Arnold, would you like to enlighten the group? What do you also have a nursing nursing informatics in your nursing curriculum? At what stage and what's in it at the moment?
So in our revised curriculum, so we already included nursing informatics as part of the program. We offered it for the first time last academic year, and well, to be honest, tele-nursing or telehealth in nursing is not yet part of the program. So we are still considering where we can put or where we can integrate those concepts. But in nursing informatics, it's basically leading towards in terms of data management and in terms of EMRs like that, but not technically about telehealth in nursing. So again, it's a challenge for us because we don't have any curriculum, or we don't have any course that really teach the skills in terms of teleconsultation. So each course with the clinical or who plans to have a teleconsult, the faculty will redesign their courses in such a way that it can integrate the teleconsultation or telehealth in particular.
Mhm. Yes. So in relation to this, so really I think all of our curriculum designing part of our heads here was really enlightened, no, by this session, no, that we can create, no, identify those skills and create a curriculum for the teaching of them, no. So there is a question regarding the setting up of a teleconsultation. So this is directed to Dr. Iris again. In setting up teleconsultation, you mentioned equipment. Any recommendations on the basic needs for setting up a teleconsultation? There's a related question to this regarding the specific platforms. Can you suggest platforms for telemedicine which are user and billing friendly?
Okay, so I put there in the chat again our bit.ly because that is part of our second document on how to set up. So for example, because it was last year when we were all panicking, like we ourselves in private practice, we didn't know how to start our telemedicine practices. So for example, we said that you should have at least a 2 Mbps per person connection. And that will even depend on your telemed platform because there are telemed platforms that require higher speeds. Second, you need to have a web camera, of course, or you can also check if whatever telemed platform you choose, will it work on a mobile phone? And most of them also will work on a mobile phone. Some of them will require apps, or some of them will be browser-based. So I prefer browser-based because it's easier for the patients to just type in the URL, and then they will be able to enter the virtual clinic. Now, if you ask me what will be friendly, docc.me, and I will put that in the chat box. It has a free account, but also, you know what, Google Meet will also be useful, and because we are talking about our students, if they have their Gmail accounts, then they have Google Meet, and so that can also be used, right? And I know someone here is recommending Sirius MD. I know a lot of doctors also use that. So really, what we need to do is check out the platforms, and then look at the features, and then see what appeals to you that you think our students will learn from. So there's many platforms now. It's not like before that there were only a few.
Okay. Still related, will there be, Dr. Tan, will there be a standard teleconsultation curriculum that will be integrated in the residency training program?
That has been my dream since last year. For in the Philippine College of Physicians, I met with the component societies. Actually, Dr. Mario Panaligan was then president, and we talked about creating first only nga a list. Like I told them, can you give me a list of what you think our cases can be safely seen via telemedicine? Because that's the list we're gonna need. If you see, for example, headache, maybe not because it might be a stroke or something that's emergency, then we'll not put that on the list. But we had difficulties really coming up with the list. But most of the societies came up with their lists, and then they will say like if something like congestive heart failure of this kind, no, it cannot be seen via telemed. It has to be face to face. So first coming up with those lists even will help us so that we know how to structure our curriculum.
Dr. C, Michael C, would you like to read your question?
Hello, everyone. Hi, Riza. You mentioned in your presentation about interprofessional collaboration. How do you ensure that interprofessional collaborative practice is employed using online arrangements? In your experience, have collaborative moments increased now than before pre-pandemic, at least in the context of rehabilitation and therapy services? I'm a notee, that's why I'm asking.
Thank you for that question. Yes, so I actually emphasized that because I would say that it has increased, but in a different kind of way as well. And our practice so far, if we would do the usual interdisciplinary care sessions wherein an OTPTSP would be handling one patient in one session, that might be too complicated for us since it would involve a lot of people in the same call, and it could be too distracting, not just for the patients but also for the interns as well, no, since there are too many people involved. So what we have been doing so far is that if there is a need for interprofessional collaboration, no, we would have so far what we have been doing is we have different sessions, no, with the different rehab professionals, but they would be consulting each other, no, um, uh, right before they see the patient, no? So that's what we are emphasizing currently, for our interns to learn as well, that if they have questions and they know that this particular patient that they are handling are seeing other professions as well, like OTs and SPs, they would need to actively consult yung other professionals that are handling the same patient so that they can apply, no, the same treatments, to, or at least supplement the treatments that the other rehab professions are doing for this particular patient. Another thing I would say is that we have been, at least for the PT side, we have been actively collaborating with physicians as well. No? So physicians have been more readily accepting our questions, no? Especially in this kind of setup. So we would really need the help of the physicians to really know if these clients are cleared for a telehealth setup. No? So I mentioned that we have an eligibility criteria before we see our clients, no, for telehealth. So one of those things is one of the processes that we go through as well is we actually ask the particular physicians that refer them to us if what would be the safety considerations that they would think we would need, no, when we do our telehealth sessions with the client. And if we see those safety concerns, no, at paano ba namin sila i-refer back? Do they need emergency care? How do we refer them to emergency services if things do happen during our telehealth sessions? No? So that's another thing that has been really been implemented during the past year. And then lastly, in terms of collaboration, ang pinaka nag-increase, I would say, is the collaboration with the patient and the caregiver, since they really need to own the session. No, they are doing most of the work for us. Actually, it's just us instructing them, suggesting them that maybe they can try this one, or maybe you can look for this kind of objects in your home to use in the therapy sessions. But for the most part, it's really coming from them, the input, and we work with their input, no, during the session. So during the sessions, really need their active participation, that they really are part of the session, no, and we see that they have been really seeing the changes themselves, no, even without our explicit na saying na you have been improving in these portions of your fitness, or we can see that you're improving this, ito yung goal mo, kasi they can really see na sila yung nagsabi nun before, sila yung nag-own nung activity, they really invested on doing the activities on their own. So for us, actually additional na ano na lang kami na support for them, no, when we do the therapy sessions, no. So that's really one of the new things that we see in terms of collaboration.
Thank you. Can I just add one more question? Sorry. Pwede pa ba, Dots?
Go ahead.
Thank you for mentioning how the collaboration between the professionals and the families and the clients have been more emphasized with the during this time na using telehealth or telemedicine. I'm just curious, maybe for the audience here in the Matlisem, are you using any technology-mediated applications where you therapists, physicians, and other health professionals parang plan together using any applications? If you're using it, ano yung masasuggest mo sa kanila? Kasi even before the pandemic, EMRs have been using collaboratively in other countries, diba? Talagang pag nag-input yung neurologist doon, makikita siya ng nurses, makikita siya ng OTs, PTs, tapos naka-color code siya. But that's because sa ibang ano yun, talagang naka-system siya. Pero
Right.
sa atin dito, ano yung ginagamit natin? Kaya, yun lang, last na yun. Thank you.
Yeah. So far, actually, wala pa kaming ganun ka-explicit na system. At least for consulting with physicians. Kasi we've been getting referrals from different clinics, different hospitals as well. So we don't really have one specific platform that we use when we consult with the physicians themselves. So at least when we get the referrals from them, ang pinaka-explicit that we need to get is yung pinaka-basic na communication natin, which is mobile numbers ng physicians, no. For the telehealth telerehab na sessions with other health professionals, since we are working in the same platform, we usually work together in what is available dun sa departments. So for us, ang pinaka-primary na ginagamit namin is Zoom pa rin, and Viber, yun. So yun yung usual means namin of communicating and asking questions when we consult with each other. So kanya-kanyang setup lang kami usually when we do this. So wala pa siyang particular system wherein we can all see each other's works. But I guess ang pinaka-common na for us na if you don't really need the direct na explicit na consultation, or just want to see the documents of the other health professions handling the same patient, we actually have a common drive for our clinic, no, so sa CTS. So yung common drive na yon, you would actually see kung sino yung mga kasama niyang mga health professions na nag-handle doon, no. So kung may document na sinubmit galing from, for example, OTs or SPs, we can see those documents and their recordings as well, no. So explicit lang doon for data privacy purposes is that when the patient sign, no, yung record, yung informed consent nila, kailangan clear sa kanila na kapag in-upload to sa drive ng clinic, makakita nito ay not just yung OT or yung OT interns, makikita din siya ng mga other learning professionals that are handling you, or basically handling you. Sila yung may major access din sa drive. So that's also something that we also use.
Dots, you're unmute.
Mute ka, Dots.
Okay, so another thread of question, well, just one question, but it might spark a thread, no? From Teddy Abellera, no? Can you comment, this is for everybody, can you comment on the effect of telemedicine on health inequity in the perspective of the students and also of patients, especially in the Philippine setting? Very exciting question.
Ano ba? All right. Okay, I currently have a protocol that was approved by the REV, and we're starting it already. We're assessing the quality of telephone triage in the diabetes clinic for our endocrine fellows. And I was telling Sir Arnold teletriage, and I was about to put the link to this article. There's already an assessment tool for assessing quality telephone triage, and it was way before the pandemic. And the findings there, Sir Arnold, is that nurses are better at teletriage than the doctors. Okay, so in that teletriage checklist that they have a list of what do you ask, and then so there's like a checklist. If you ask about this, and then they found that the nurses are more thorough when they go through the checklist as compared to the doctors. So I don't have the results yet, but because of inequity, really, a lot of our patients in the Philippine General Hospital, they call. Okay, so that's very hard. As a private practitioner, I don't accept calls for telemedicine. I only do video, the requirement for me. because it's so hard if it's just the phone, it's only audio. I can't even see the patient, right? And that's what happens here at our hospital. There are a lot of calls. So now we're trying to study the quality of the consultations that are done by telephone. Like if you're a new patient in the diabetes clinic, what are the things that have to be asked? Like for example, do I ask, do you have a glucometer? What was your last blood sugar reading? What is this? Do you have the following symptoms? Yes or no? So it's gonna be like, I don't know, like a call center agent or something like how they do the 911, right? That if you answer yes here, and then there's another set of things that you need to ask, things like that. So I'm sure that our trainees, our residents and fellows, they have been doing telephone consultations in the PGH since last year. We have developed these skills, but nobody has written about it or actually evaluated it, not to my knowledge anyhow. So we need to write those things down, right? So telephone. And when I talk about this elsewhere, they look at me strange because, you know, in the more affluent countries, they always talk about video. But I'm telling them, no, we need to do also telephone consultation because that's what we have locally. Not everyone has good Wi-Fi.
Interesting. Okay. Arnold, did you want to say something?
Yes, ma'am. Yung sa amin naman po, yung example na gagamitin ko is yung sa community health nursing po namin. No? So, in the rural setting po kasi, tinry din po namin na makapenetrate ng online, no? Yung mag-aalaga ka pa rin ng family in the community, pero online na or tele-nursing or using mukhang doon din po nakita na highlight din yung yung hindi pagkakapantay-pantay din ng mga nagiging clients po kasi hindi lahat din po ay afford or meron sila ng gadget na kailangan. So parang nalilimit kung sino lang yung magiging pasyente. Pero we're trying to address yung concern na yon kasi ang gagawin po, nakikipag-partner po kami with the barangay health workers. So initially, meron po kaming plano na yung parang pahihiramin pa ng laptop yung mga BHW, yung mga barangay health worker kasi sila yung magdadala ng laptop kasi sila yung pupunta doon sa site tapos kakausapin nung estudyante namin parang gano'n. So yun lang po, yung question I think talaga yung tungkol sa equity talagang with this advancement talagang lalong siguro na highlight din niya itong mga ganitong concerns and talagang parang magiging challenge for the mga hindi kakayanin yung ganong setup po.
You mentioned laptops. What about the smartphones? Are they appropriate for teleconsultations?
Yung ganun din po yung katulad din po nung binabanggit ni Dr. Iris, parang medyo mas po kami for video conferencing po kasi Kasi yung nung binanggit namin, mga facial expression, non-verbal, verbal, mga ganun po yung sana. Tsaka kung medyo video conferencing, medyo nakaka-capture na rin yung family kasi medyo, yun nga po, different levels of clients yung inaalagaan. So from individual, family, population group, and the whole community na rin po. So parang mas appropriate po siguro kung yung Pero siguro yung maliliit na intervention na kung kailangan lang ng interview, yung phone pwede naman po. Pero siguro yung kalakihan po ng aming mga intervention ay mas magandang ma-deliver kung ito ay video conferencing po.
Okay. So this video conferencing also has really broadened, no? Hindi lang naging interprofessional pero the whole family din nakasama na sa so there's really a widening of the number of people involved. Okay, there's a question to all our resource speakers. Teka lang, nawawala. Where did it go? It was from, I remember it was from Erlene about to all our resource persons. Is the link between PGH's online consultation request and appointment system being utilized now for our health science students' clinical exposure? Can you share how is it progressing so far?
Mauna na po ako kasi yan po yung naging malaking challenge for nursing po. Kasi unlike I think dun sa camp tsaka sa med, sila yung nilalapitan ng mga clients. In nursing po kasi, unlike before na, kasi kunyari mag-duty kami sa ward, captured yung patients namin, parang ganon. In the community, ganon din. Kami yung naghahanap ng pasyente sa community, hindi sila yung lalapit sa amin. Meron lang po kaming mga parang mga points kung saan kami, halimbawa in the health center, yung mga nagpapa-check up doon. And meron din po kaming mga parang criteria, no? Yun yung naging issue or naging concern namin with OKRA. Kasi kung magbubukas kami, parang yung nursing, bibigyan kami ng another set of landline yata, parang gano'n. Tapos parang ang worry, what if dudumugin din kami ng tawag? Kaya ba nung number of students namin? Tapos ito lang. Tapos marami pa po kaming mga medyo parang concern about ano lang yung help na kaya na. Kasi syempre yung estudyante po, hindi niya kaya lahat sagutin. Parang gano'n. So kailangan din namin na i-filter lang ang itong level na to, tungkol lang to sa prenatal care. E paano pag may dumarating ng ibang yung ganun po, may mga ganun po kaming mga nagiging parang mga challenge na inaayos pa rin namin para maging parang mag-work din sa amin yung gano'n na meron din kaming sarili or isang idea yung makikipartner din kami sa doktor para yung patient niya dadalhin sa amin, parang gano'n po kesa sa parang may sarili kaming parang local number, parang gano'n. Tapos another issue rin po nung sa OKRA nung OKRA, kasi yung sa amin po, medyo heavy kami on supervision. So, parang ang tinitema po namin, parang call center, kailangan naririnig din namin kung ano yung tinatanong nung pasyente at sinasagot ng estudyante. So, kailangan din po medyo may ganong system na parang pwedeng pumasok yung teacher anytime para kung may sasabihin or merong kailangang ganun po. So, medyo ganun yung mga kailangan namin siyang ayusin in terms of the design and also in the system na pwede namin Pero katulad po ng binanggit ni Prof. Erlene, yun po, OKRA, yung sa OPD po ng PGH, yun yung isa sa mga kino-consider namin. Kaya magkakaroon po kami doon. Yun nga lang, meron lang po kami mga pinaplan siyang ganyan mga concerns.
Okay. Irene?
Online consultation requests appointment. So our problem is there are people who want to consult, they are told to go online to OKRA, but they cannot go online. So what do we offer them? They call the BNOC. So the people at the BNOC, they answer, and then, for example, the patient will say, I need to schedule an appointment for my diabetes. And then they open up the OKRA site, and then they enter the details for the patient so that they can get an appointment. And I know because I've tried to set up an appointment myself on OKRA. So there are a lot of fields. And so it would really help if you had someone there. And I suppose, I wish Dr. Diana Lachico was here because she would know more about the details. But in my head, I think that would be good training for students. They're the ones who actually have to fill up the form because then they need to have more detail. They might ask some student questions maybe to make sure which clinic will I deck this patient to, knowing that these are the complaints. So they take, the preliminary history. And I know that in other telemed platforms that are for volunteers, there are students volunteering there, and I also have friends who volunteer in these telemed platforms, like for the Office of the Vice President, and they tell me sometimes, the endorsement was very complete because it was actually a postgraduate intern who took the call before the call was transferred to me. So I know that, there are uses for these phone calls that are triaged, not only by students, or residents perhaps.
Okay. So perhaps in this designing the systems, telemedicine systems, maybe we have a lot to learn precisely from the call center industry because they've been there for several decades, at least, and successfully at that. So we're pretty successful in that industry. So perhaps we can actually study and translate what is needed for our own field. Okay. I do not have any more questions.
Dot, I have one.
Okay, sige.
There's a question. This is for all. Um, how did your department or your college orient or train its faculty in teaching telehealth skills?
Siguro mauna na po ako kasi medyo yung sa amin po kasi medyo napasabak talaga kami agad-agad. Kasi yung una naming tinry for telehealth or telenursing is yung mga fourth year namin. Kasi yun nga, kailangan nilang graduate. So kailangan silang bigyan ng parang or kailangan silang mag-design kami for them ng something. So to be honest, hindi pero we're learning kasi ngayon also from yung pinresent ni Ma'am Iris and ni Liza na talagang yun nga in the training itself. So kami medyo nag-rely on yung talagang ginagawa lang talaga namin. So parang nakasabay lang siya in the delivery. Pero yung prior training to that, parang ganun. So siguro isa yun sa mga pwede namin i-raise or pwede namin i-consider also in that parang anong tawag dito in terms of faculty development then as sinabi nga parang doon na rin naman talaga kami papunta in terms of service delivery rin po. So yun lang also in the students no hindi kami ganoon nakapag-train so kaya medyo naging challenge din yung doon sa faculty kasi habang ginagawa yung program saka rin nila nililista yung mga dapat nilang kailangan matrain din yung mga bata. So and medyo may konting sense of urgency kasi nga yung mga fourth year namin ito so kailangan din nilang graduate sana on time parang ganun. So medyo na-push lang kami talaga na ma-design. Pero right now nire-revise siya ulit para mas maging maganda at mas maging productive yung mga magiging learning experiences ng mga bata.
To add lang din siguro on our end. So, parang safe actually kami ng situation, I guess, with the nursing na parang we really have to try it ourselves before we teach it. So, before we did the internship program last academic year, yung parang yung period in between starting the new academic year, parang that was the period that we were all already looking into the fact na okay, we can't do face to face, so the faculty really have to shift how they will do the internship program this year. So all of us initially kasi all of us are already volunteer clinicians of our clinic, yung CTS, no. So when our previous patients consulted us if they would be able to still get the therapy services that they would need this coming year kasi they know that they need to wait for the interns before we start we took actually that opportunity na yung mga faculty muna yung mag-try nung tele-rehab setup. So para makita din nila yung ano ba yung logistics na kailangan, what are the equipments that you would need, what do you expect from the patient, how are you going to do this. So we had, I would say, a few weeks na preparation time for that. Now we had to try it out ourselves, no. And then similar na situation na while it was being developed last academic year, kasabay nung mga graduating interns namin, yung 5th year namin, doon lang din kami nakapag-try nung telehealth. So this academic year, yung mga experiences na yon before we started this academic year, we actually went through the processes that we did. We talked amongst ourselves in the department na how did we go through this kasi last year we were just doing our own thing, no? Parang nag-trial and error lahat ng faculty since we have different kinds of patients, no? So parang iba yung pag-handle ng pedia, iba yung pag-handle ng adult, iba yung pag-health promotion na patient. So we sort of pieced together a protocol, no? This was headed by Professor Mia Rator as well, where we jot down all of our ideas na how did you do this part? How did you do this part? And then we sort of compiled those revisions that we did. So we have this formal document right now that we are using for the whole internship program that the faculty can use. And at the same time, it's being shown to the students na this is what the faculty is using to teach you. At the same time, you should know that kailangan madaanan mo to as a student na before you graduate, this protocol is what you should be undergoing with the faculty. So nagkaroon kami ng ganong setup to make sure din na outcomes-based pa rin siya in general, no, na ma-achieve nila yung parang checklist ng student na nakapag participate ako sa ganyang part ng activity, etc. ganyan. At the same time, meron kaming parang guidelines for the faculty, no, na parang pag nandito ka na sa ganyang process, pag nasa assessment ka pa lang, ito yung mga pwede mong gawin, ito yung kailangan mong i-ready, etc. Ito yung kailangan mo sabihin kay student, ganyan. So may mga ganun kaming documents, no, na guide for the faculty. Yun po.
I think lahat po tayo ganon, learning on the ground as we go. So I shared in the chat a rubric I made for our second year students who rotated with us in endocrinology. So since there were no preceptorials in the OPD or in the ward, what we did was the fellow, at the time it was not a surgeon, so the fellow had the patient with him or her, and they were in Zoom, and then we were in Zoom with the students. And then the students were running the consult. So nag-divide pa sila. So sabi ni student, ako yung sa history, ito yung tatanungin ko. Tapos yung next set, ito yung tatanungin ko. We really had fun though. And ang problema was yung sa PE. So it was kasi in our office. So naka-laptop yung fellow namin. Sabi ng student, I want to see the foot of the patient. So hindi namin alam paano namin paano yung laptop, paano iatas yung paa doon, yung gano'n, kasi hindi siya mobile phone. And so even though na-frustrate yung mga students, sabi na, ma'am, di namin nakita yung paa. Pero ganun pala yun, no? Pag telemed, ganyan. So what we only had was, I sent this rubric to the students, and then I sent the rubric to the faculty. But this rubric only evaluates website manners. And so I realized that I needed another rubric for yung the case. Kaya nga yung case vignettes kanina, yun yung kailangan ko pang gawin. Kasi natanong ba nila yung mga dapat nilang tanungin? Nagawa ba yung mga maneuvers na dapat gawin? Is a different thing from were they nice to the patient? Were they polite, etc. So, did they maintain eye contact? Like right now, I'm trying to look at the camera para mukhang nakatingin po ako sa inyo. Yung mga ganon. So, or pag nag-notes ako, baka gumanito ako, tapos akala ng patient may iba na akong ginagawa. So, yun po kasi yung sa website manner.
Okay, so thank you very much for that. So the nice thing about when something is so new, is wala pang rules. So aside from we're left to our imagination and our creativity, at the same time, wala pang rules and policies to limit us. So definitely, yeah. So we are free, to design as we see fit, and we will just, as you said, design on the ground as we are hit the ground running, and then we will just share best practices and learn as we go and improve the systems as we go. And we have venues like this one precisely to facilitate that sharing. Okay, so we actually reached the time allotted for us, even with the extra time given. So we, but I think, Claire, if there's no other urgent question, I think we have exhausted the questions. So your questions, and now it's our time to ask the questions. So this is the, so now is when we will have our quiz, or natawa si Iris. Yes, that is what we have here. We have nothing ends, no teaching opportunity ends without assessment. So we have this little fun interactive assessments at the end of our seminars. So I will turn over, I will say goodbye, because after this, I will turn you over to our Dean and quiz show master, Melflor Atienza.
Okay. Hindi naman siya quiz na quiz. Para lang siyang game. Okay. But thank you, Dots. We'd like to thank our speakers too for giving us a lot of pointers and experiences for our own learning. I was actually the one who asked the last question on faculty development, because I thought that, as teachers and as a training center, as a college, medyo concern namin lagi nung tama ba yung alam ng teacher para tama din yung may ituro niya sa mga estudyante niya at tama din yung magagawa sa mga pasyente nila. ano nga, no, mahirap nga yun. Paano ba itataas ang paa? Pero ngayon, di naman ko kayo patitingnan. I'll just ask you to log into, if you were here, if you were with us last time, then I suppose you're familiar with our game, which is the yung Mentimeter game. So if you haven't done that, you can use your mobile, you can use half of your laptop, and go to www.menti.com and enter that code and write your name. Mas mabuti po siguro talagang pangalan nyo kasi there's a prize for the highest pointer, which is data ba, Claire? O totoo yun hindi joke. So may utang kami kay Abby Tamayo, the winner of last month. Hindi pala namin na-send. So it's for 500 pesos worth of data. Or kung ayaw nyo ng data, edi ibili nyo ng pagkain. Okay. So yeah, I'm seeing about 23. Sana mas marami pa. So maybe a few more minutes. The faster you click or you answer, the higher the point. And we're having limited number of words, kaya medyo bitin yung ibang tanong. So makinig na lang kayo sa akin para makita niyo yung the whole of it. Yan, sige. We're 159 in the room. Sana naman maka 100. Wala naman pong, hindi naman babawiin yung CPD units pag hindi kayo nakasagot at saka hindi rin naman mapopost yung inyong name. So, join us. Paano bumoto? Yeah, you have to go to menti.com and then enter that code. And then you'll be asked for your name. It's better if you do it on your phone kasi baka, pero yung iba gusto sa laptop para kita din. Kaya lang hahatiin yung laptop niya. Ang Menti is actually integrated or can be integrated into the Zoom, but for us, dahil UP account itong ginagamit ko, we have to ask permission daw. Kaya hindi na, okay na din na ganyan. Siya. Charan. Ay. Okay. Ayan na po kayo. Yan. Baka meron pang mga ilan na napapasok. Start na. Yan, a good number. We are 70. Answer fast to get more points. According to the guidelines on the use of telemedicine in COVID-19 response, the gold standard for clinical care is now telemedicine. B, patient-physician relationship is based on a face-to-face interaction in telemedicine. C, physician who initially sees the patient is responsible for coordination of care. And D, serious conditions should be managed via telemedicine. 3, 2, 1. Yan, so correct. The physician who initially sees the patient is the one responsible for it. Gold standard, sinabi ni Ludi kanina, inulit-uli ni Iris, is still face-to-face encounter. And of course, in telemedicine, kaya nga telemedicine, so hindi siya yung face-to-face encounter. And serious conditions, we don't want to manage that totally using telemedicine. Let's see. Tingnan natin. Generin and Luhan. Si Tiger Baby and Froy. Yan ang ating top 3, pero meron pa tayong 8 questions pa. Second question. Which of the following is or are rights of the physician conducting telemedicine? Autonomy and privacy. Physician to, hindi patient. Right to obtain all information about the patient, whether or not related to the disease. Withholding the plan to minimize the patient or caregiver anxiety, and all of the above. Hindi naman po test construction ito. Kaya merong all of the above option. Okay. Let's see your answers. Yan. Hindi po laging all of the above ang tama. Autonomy and privacy. So this has been well discussed by Ludi and the other presenters. Right to obtain private information, all kasi nilagay ko, all private. And in-specify ko even those not related to the problem. Withholding plan is not our right kasi it's the patient's right to understand the disease, or at least yung caregiver kung child yon. And so, next, tingnan natin ang leaderboard kung nagbago po ba. Nagbago. Si Annalisa, si Gab, Wiwo. Ganda ng mga pangalan. May Casper pa at may Cake. Okay. Sige, tingnan natin. Next question po tayo. According to RA 10173, yan lang naman po about data privacy, personal information of the patients must be collected for specific uses which can be determined at a later time. So hindi pa naman lahat ngayon. Adequate but not excessive in relation to the purpose stated and retained for a period of 5 years before deleting. So specific. Yan, wala na po yung all of the above. Okay, let's see your answers. Yan. So most of you answered adequate but not excessive information in relation to the specified purpose. So we determine the uses at the time of the consultation at the start. And we retain it for as long as necessary. So kung may sakit pa din yung pasyente for 5 years, di ma-maintain pa yon. Kung 1 day lang, 2 days, magaling na, we just keep it for as long as it's needed. Okay, tingnan natin. Yan. Okay, so si Annalisa, si Teddy, and si Gab. Okay, kita nyo, 5 points lang yung mga a millisecond lang yun. No? So, we as teachers, students, we also have to be conscious about things like informed consent, the process, the referral, how privacy is ensured, as well as the risks of tech failures. And napakahalaga, it's important to build everything on mutual trust, respect, confidentiality, and of course, while maintaining quality of care. Next. Yan. Kalagitnaan na tayo. Using technology to provide healthcare remotely to address the continuous increase in the demand of care is called an entrustable professional activity, virtual clinical practice instruction, telehealth, or technology-enhanced teaching. Halos lahat nakasagot na. Siyempre, telehealth. Ang topic natin ngayon, hindi telehealth yan. So, Arnold defined this during his presentation. Technology integrated or incorporated into healthcare. Yung iba kasi is teaching, technology-enhanced teaching, but yung telehealth is really mainly healthcare. But of course, our session today is really teaching our students how to demonstrate those skills. Yeah. May umaakyat, no? Pero Pearlcon, Gab, Teddy, Casper, Vivo, Elsa, Pearl, ini-specify pa, Michael, not Mike. Okay. And next question. Which of the following is or are nursing telehealth and trustable professional activities? Providing health promotion remotely, monitoring body functions and lifestyle, supporting patients in the use of technology, all of the above, or A and B. A and B is providing health promotion and monitoring body function, and not including teaching patients how to use technology, kasi hindi naman natin yun ginagawa na. Okay. Yan. Okay. Yan. Lahat yun. Oo. Kung nasa test construction class ko kayo, sasabihin kong, please avoid all of the above or A and B only. Pero ito naman for fun and for summarizing everything. So all of the above po yan, which emphasizes the fact that we have to support our patients, their caregivers, in the use of technology. So tayo din po ang magtuturo o yung student din natin ang mag-orient doon sa kanilang patient in case they're the ones doing it. Tingnan natin nga kung may nabago po sa leaderboard. Talagang mga okay. Si Lim, si Genevieve, at si Ed. Yan, pupunta na tayo sa telerehabilitation. Kanina, this was clearly stated. Examination, evaluation, PT prognosis and plan, PT interventions, or all of the above po ba? May nagkamali pa dito. Lagot kayo kay Raisa. Dito na masagot. Ayan. Yes. Ayan. Sabi ko, hindi naman laging all of the above. Pero minsan, all of the above ang sagot. So, meron pa din dito kasama yung PT diagnosis. No? So, again, yung earlier, Arnold mentioned the outcomes of significance and then the EPAs or yung which are really to be our tasks which our trainees should demonstrate after they have achieved those competencies. So ngayon naman ito yung actual implementation was emphasized by Liza in her presentation. So all of those aspects can actually be taught using synchronous and asynchronous sessions. Hindi masyadong magkakalayo. Okay. Okay. Asynchronous method in obtaining history for telerehabilitation. Interview of actual clients real time through Zoom meetings, asking a family member questions during a video call with classmates and teacher, kasi wala nang space kaya hindi ko nalagay yung teacher, asking caregiver or client to answer a Google survey with the questions that you would have asked in an interview, or demonstration of the teacher via Google Meet on how to do an interview. Asynchronous method. Yan. Correct. So pag asynchronous, syempre, hindi siya synchronous. So, hindi siya yung Zoom meeting, hindi din siya yung video calls or Google Meet. Kaya Google survey that they can do on their own prior to the synchronous session. Yan, tingnan na natin. This is the second to the last question. So kung magmamabilis kayo, ngayon na yung panahon. Kasi last question na po tayo, although may dalawa pa dyan. Pero this is the last question. Okay. Si Annalisa, Gab, Teddy, Casper, Elsa. Yun ang 5. Yan. Evaluating patients in telemedicine includes identifying need for in-person visit, managing serious medical conditions purely through telemedicine, and expressing sympathy. So ay evaluating patients. Specific for evaluation. Okay, so it's yung evaluating the patient is really to identify whether it can be through telemedicine alone or there's a need for an in-person visit. And then, of course, managing serious medical conditions is not encouraged, or although it can happen in telemedicine, pero we are limiting the question to evaluation. But in expressing empathy, it's throughout the consultation naman yun. Ayan, tingnan na natin. Si Annalisa. Okay. So, clap, clap, clap. And bang isa? Meron pala last question. This is the inter-visit simulation. Do you remember that? Paano ba yung example doon ni Iris? Nursing e-message sent to the participant of patient that the patient is decompensating, an actual patient consultation, or a written examination on patient management. So how can you assess telemedicine skills through inter-visit simulation? This is teaching as well as assessment. Yeah. So, yan, may e-message na matatanggap kasi siya inter-visit. So, hindi siya during the visit. Okay? Yan. So, tingnan na natin. So, ito na talaga yung last. Natanong pala. Okay. Ayan na. Congratulations to Annalisa. Okay. Please email us and Claire will contact you. Yun na eh. Sa iyong napakahalagang premyo. Okay. Annalisa. Mamaya after the last one that I'll show you, will ask you to show yourself on video. This is for everybody. It doesn't have points, but please state one take-home point that struck you the most in today's symposium. Write a phrase, write a sentence, wag naman pong reflection paper. A few words or one short sentence, pwede rin one word. Take-home point yung ngayon. New trend, it's evolving, it's here to stay. Yeah. Informative, wiser. Yan ba yung wiser physician? Adaptation is a must. Amid the pandemic, paano ko ba ito ibababa? Ayun, teleconsultation is an important part of healthcare delivery. It's a process. Scary! Okay. Evolving, flexible, doable, but limited. is the future, and the future is now. Providing healthcare can still be possible amid the pandemic through the use of available technology in order to provide care for those who need it. Importance of telehealth is this in this time of COVID pandemic. Innovative and implementable ba yun? Telehealth is timely. No turning back, mga kapatid. Humbled by the learning. Telehealth is here to stay. Informed consent at every consult. Telehealth. #WeWo. Meron pa siyang card. Challenging, including telemed in everyday life. Telehealth is a new normal. Future of health practice, learning as we go, making a way in every loving way. That's nice. Telehealth is not a luxury, but a necessity. Enlightening as to the innovations, assessment, planning, implementation, and evaluation are still needed. Correct. #game na. Thank you. Thank you for all of those. We're happy that you found this session interesting, informative, and telehealth as something innovative, necessary, timely, and doable. Okay, back to you, Claire.
Okay, may we request our speakers to open their video and for our moderator as well to receive our certificate of appreciation. Okay. Let me first read the citation, the certificate. National Teacher Training Center for the Health Professions and University of the Philippines, Manila, and Dr. Corazon Paulino Gonzalez Memorial Foundation Incorporated present this certificate of appreciation to Professor Arnold B. Peralta for his invariable contribution as speaker during the online monthly seminar on developing teleconsultation skills in health sciences students, given on this day of October 25, 2021, signed by Dr. Melflor A. Atienza, Professor and Dean of NTT CHP, and Dr. Erlyn A. Sana, the President of the CPG-MFI. It also for Professor Raisa Marie R. Ruiz, Dr. Iris Tiel Isiptan, Dr. Lourdes Marie S. Tejero, and for Dr. Lourdes Dorothy S. Salvacion for being our moderator for today. May we request also everybody to open their videos and to have our
thank you
opportunity. Okay.
Claire, kunan ko lang muna yung speakers, moderators, and kayo-kayo ha. Wait lang. Kayo na in-spotlight ko. Wait lang. And then I'll take the group picture. Ayan. Sige po. Open po tayo ng videos. Yahoo! Let's do this.
Huwag muna kayo mag-chat ng pasasalamat kasi
opo muna kayo
matatakpan yung kawawang nasa baba.
Kawawa po yung matatakpan. Ayan, no? Sige. Sige po. All smiles. Meron po tayong 7 frames, no? So, smile lang po kayo ng smile. So, first frame, 1, 2, 3. Sandali lang po. Okay. Punta tayo sa second frame naman po. Smile lang po ulit. 1, 2, 3. Okay. That's the second frame. Punta po ako sa third frame. Smile lang. Maraming salamat po.
Onyx, pakita ka!
Oo, iba. Di pa nag-grab na eh. So, fourth frame na po ako. Pasensya ka lang po. Ayan. Ayan. Fourth, fifth na po akong frame. Smile lang po ulit. Hindi ko alam kung nasan kayong frame eh. Ay, hindi nyo alam pala kung nasan kayong frame. Yun.
Yes, Bao! Long time no see!
Kaya Tawa lang po ng tao. Ay, smile lang po ng smile. Di pala tawa ng tao. Smile lang po. Ayan. Second to the last frame na po ako. Okay, last frame na po. Ito na po. Smile. Ayan. Marami pong salamat. Nakuha ko na po. Aray ko na po.
Thank you. Okay, so to our registrants, you of the online inter-university workshop for the synchronous sessions on November 4 to 5 to be followed by the asynchronous activities and this the CPD
present mo yan.
Sorry. Iba ang na-share. Okay. So again, to our registrants to the online inter-university workshop, this is actually a rerun that we had last August. The synchronous session is on November 4 to 5 to be followed by the asynchronous session activities, and the CPD units have been applied for the said workshop. And for the last topic, of course, this is the last but not the least on the monthly seminar entitled Mainstreaming Online Teaching and Learning in the Health Sciences on November 29 to be given by NTTC-HP's College Secretary, Dr. Emily D. Dicolen. Once again, we will email you again for the Zoom registration once finalized. For other announcements, please visit our website at https://nttchp.upm.edu.ph. You can also email us at nttchp.upmanila@edu.ph. Once again, on behalf of the NTTC...
Yung winner natin, ha? Nasaan si Annalisa?
Oo nga.
Pwede bang mag-hi?
Annalisa? Nasaan siya?
Yes! Okay, please email us. And Claire will answer you.
Okay, thank you po.
Congratulations.
Okay. So, on behalf of the NTTC-HP and the Corazon Paulina Gonzalez Memorial Foundation, we would like to thank you everyone for joining us today. We hope you learned as much as we did. So please don't forget to fill up the client satisfaction survey. It's in our chat box. And once you accomplish the survey, you will automatically receive your e-certificate of appreciation. So please write the correct email address. Okay? And for you, and we would like also to remind everyone that this form will be open until tomorrow at 5 p.m. only. Okay? So thank you very much. We'll see you again next month for the last series of our monthly seminar. Thank you and keep safe, everyone.
Congrats, Claire. Congrats, Dots.
Asa na yung
Sis
form?
Bao! Ba! Thank you to our